Okay, I think we've got a lot of people here already, so we'll probably start today. So welcome back, everyone. Glad to see you here. If you're still here, thanks for staying this long. Everyone, if you could have your cameras on, just so I know you guys are attending the class, and that way I have a good idea that I've got enough people. Oh, beautiful. Dr. Ruth is on her way to somewhere. Beautiful. Awesome. Alrighty, guys. Oops, what have I done? Let us get our class started. You guys can hear me perfectly fine, right? Yes? No? Yes? Awesome. Beautiful. Okay. So, yeah. Welcome back, everyone. I'm glad you guys are here. This will be our last lecture when it comes to endocrinology, and thankfully, you guys will be happy to know that this is the last time you'll see me. I won't be coming to haunt you back for any other subjects, hopefully not. But today will be a really good conclusion for everything we've done. It's going to be a very sweet and short lecture. I know the schedule says 4 hours, but you guys don't have to stress. You guys can go to sleep early tonight. It'll be hopefully around 2.5 to 3 hours. There's not that many topics. It's just the miscellaneous topics. And what I'll do is I'll cover electrolyte imbalances as well. Why? Because those are quite important to recognize how to treat and how to understand. And at the same time, you'll be getting ECGs for them. So it's really important you guys know that what the ECGs look like. You guys aren't confusing it with like TCA overdose or some sort of other illness. You guys, it'll be very, very important to understand what hyperkalemia looks like on the ECG, especially when it comes to emergency medicine. All righty, let us begin. Let's share screen. Awesome. You guys can see my screen, right? Beautiful. So yeah, so far in our first lecture, we covered all our thyroid diseases and our parathyroid diseases, right? We looked at the differences between all the different kinds of primary, secondary, tertiary, hyperparathyroidism, and hypoparathyroidism. At the same time, we looked at thyroid diseases and we saw it was whether it was primary, secondary, or tertiary. And for the sake of the exam, I think there's a big emphasis on primary and secondary. At the same time, we also covered what nodules look like. How do we know? Does anyone remember how we normally categorize the different kind of nodules? We do them in two ways.
Multinodular and single,
Yep.
and hot and cold.
Yep, excellent. Multinodular
Toxic and non-toxic.
Yep, functioning, non-functioning. There's multiple ways. So hot, cold, non-functioning, non-functioning. Is it singular? Is it multiple? And what about when it comes to the parathyroid diseases? We kind of looked at it like, once again, it also depends on the size, right? And that same kind of classification is going to happen today as well, especially when we look at diseases. So yeah, I think that was a good rundown of the first lecture. When it comes to our second class, we looked at diabetes mostly. We covered lots and lots of diabetic disorders, and most importantly, we covered diabetic complications. We saw all of the things that diabetes does. It does a bajillion different things, and it has like a million different symptoms. But it's very, very important that we understand the complications and how to manage them. Each of them, whether it's a diabetic foot ulcer, whether it's HbA1c monitoring, whether it's how to diagnose it, whether is it autoimmune related, is it not? Those are really, really important differentials to have. We covered our adrenal disorders. Mostly we looked at things like Addison's disease. We covered things like Addisonian crisis, covered things like Conn's disease and bilateral adrenal hyperplasia. We said that there's different treatments for them. We covered Cushing's syndrome. And at the end, we briefly covered congenital adrenal hyperplasia. Lots and lots and loads of different things. But yeah, probably this slide, number 13, is probably the most important thing you'll have to know. If there's anything you need to remember really, really well, it's this one. This will save you a lot. And of course, you guys have the slides, so you guys can always go back and look at it. But yeah, we discussed that there's multiple different tests for each of these conditions. We look at different things. The etiology is different, but there's loads and loads to cover there. Now, as I promised last time, we will start this class once again with a practice session. We will cover things from our first and second endocrinology lecture. So I think it'll be a lot more interactive, and it'll be a better way to recap everything we've learned. So let's start off here. Beautiful. Endocrine practice part 2. We'll get, there we go. Some of these questions you guys have covered, some are in our lecture, some of these are new concepts, but they still pertain to the subjects that we've done so far, or the topics we've done so far. So some of these questions may be a bit difficult, but I think it's very, very important to at least mention them briefly. So we'll get Dr. Basira to cover our first question.
Hello, everyone. An 18-year-old student is brought to the emergency department by her friend with a several-hour history of abdominal pain and vomiting. Her friend notes that the patient is confused and that her breath smells like pear drops. Prior to becoming so unwell, the patient had complained of having a cold. The patient has known type 1 diabetes mellitus that she manages with an injection of long-acting insulin once daily and short-acting insulin with meals. A finger prick test confirms a capillary blood glucose of 17 millimole per liter and ketones of 4 millimole per liter. As well as fluid resuscitation, how should this patient be managed? Start fixed rate insulin and continue both regular long acting and short acting. Start fixed rate insulin and stop both regular long acting and short acting. Start fixed rate insulin, continue regular long acting insulin and stop regular short acting insulin. Start variable rate insulin and stop both regular long acting and short acting insulin. Start variable rate insulin, continue regular long acting insulin and stop regular short-acting insulin.
So lots and lots of different options here.
Yes, and the patient, according to it, the patient is in diabetic ketoacidosis, I think.
Yep, absolutely.
So,
how would you know that this is an HHS, for example?
hyperosmolar.
Yep, the hyperosmolar.
Yeah. Oh, yeah,
disease.
because
Okay.
the blood glucose is very high, 17.
Yeah, but one thing in particular.
No ketones.
The Pierce,
ketones.
Pierce drop
Ketones, yes.
smell.
Yeah, and the Pierce drop. But most importantly, remember, in
Yes.
HHS, you're not going to have ketones.
Yes.
Yeah,
And
and once
it's
again,
more high, like 25 millimole per liter.
Yeah, in HHS, it's also the blood glucose is much, much, much higher. But don't use that as a criteria. Always look at the ketones first. That's very important.
Yes, yes.
Excellent. How do we treat you? Just like you said, Dr. Basira, this looks very much like some sort of DKA. Type 1 diabetes, 18-year-old, he's got ketones positive. So how do you end up treating DKA is the question. But some people going with D, some with E, some with C.
I would also go for D. I don't know why, but
That's okay.
it
I'll give
seems
everyone. No, it's
correct.
there's a lot. Does anyone know how we calculate how much insulin to give to a patient? It's like generally a formula.
I think it's you do use 0.02 to 0.05 international units per kg.
You usually when it comes, yeah, it's not too far off, quite close, but usually when it comes to giving off the units, we do 0.1 units per per kilogram. So if someone, example, is 100 kilos, it would give them about 10 units typically.
Yes.
If someone's 40 kilos, it would give them 4 units. That's how we did it.
Yeah.
In this case, the answer here is, oh, lock this off, is C here. The idea is when you want to treat DKA, you want to stay from any sort of variable, right? You go at a fixed rate of insulin infusion, and you usually go for your long acting. You don't give short acting straight away immediately. Explanation is typically here. John Murtagh also has a little brief section on this where he explains the rate of infusion, the amounts we give, and how fast we need to give it. But typically we stay away from variable when it comes to treating immediately, and we give them a longer acting insulin. Excellent. Next question, I'll give this to Dr. Farai. This question is for you.
Thank you. Good morning, everybody. A 74-year-old man presents to the emergency department with intense genital pain and skin changes affecting the surrounding area. On examination, there's edema of the perineum with some necrotic areas. The patient denies any other systemic symptoms. He's known to have diabetes and states that he has recently been started with a new tablet. Which of the following medications is likely to have caused this? So this seems like Fournier's gangrene, which is a typical side effect of SGL2
Okay.
drugs. So on the list is DAB, so I'll go for A, DAB.
Okay. What about everybody else? Give everyone about 10 seconds and go on to the next one. Okay, so Dr. Farai, you're very, very convincing. I'll be very, very honest with you, but yeah, you're absolutely correct. It is SGLT2 inhibitors. They are linked. Interestingly enough, if you ask, in the UK, they still have the belief that SGLT2s are linked to Fournier's gangrene. In Australia, though, a lot of doctors say they disagree with that. They're like, oh, no, it's not a thing. It's a myth. It doesn't really exist. But no, you're absolutely correct. SGLT2s have been linked to Fournier's gangrene. And this patient, obviously, the signs of that necrotizing fasciitis is there. So the most, out of all of those diabetic drugs, the one that is typically linked with it are SGLT2 inhibitors. In this case, it would be dapagliflozin. Excellent. I'll give the next question to Dr. Macro.
Okay, 48-year-old female with history of hypothyroidism presents to the emergency department with the gradual onset of the confusion and fatigue. Her general practice records states that she has poor compliance with levothyroxine. Her heart rate is 42 per minute. Side function tests are follows. She is admitted to the high dependency unit. Which of following features would be also expected? A, loss of the consciousness. B, hyperventilation. C, hypoxemia. D, pretibital myxedemia. And also E, weight loss. And also thyroid TSH is 9.7 and also T4 is 0.2.
Yeah. So, Dr. Macro, what do you think is happening here? What is going on with this patient?
I think it's hypothyroidism, and it should be the C, hypoxemia, yeah, low metabolism, yeah.
More specifically, this is hypothyroidism, but exacerbated, right? Because they have this onset of confusion. What do we call that? This emphasis, now we have altered mental status, this fatigue, they have a history of hypothyroidism, they're non-compliant. You can see your T4 is extremely, extremely low. Your TSH is very, very elevated. What was this condition called? Do you remember?
No.
Anybody else?
Mixed edema coma.
Yeah, mixed edema coma. And one of those things we said is usually mixed edema coma, everything is low, you know? And in this case, definitely hypothermia is there. Excellent. We'll go Dr. Ruth. Can you speak? Are you still traveling?
Yeah, I'm still traveling, but I can speak.
All right, please.
Okay, a 65-year-old lady is undergoing a total hip replacement. Her past medical history includes hypertension, polymyalgia rheumatica, and asthma. 7 hours post-op, the patient becomes unwell. The post-op bloods are as follows. From the following options, what is the most likely reason for this patient becoming unwell? So the labs, HB is 96, so a bit low, platelets 256, normal, WBC 7.8, normal, I think. Neutrophils 5.7, also normal. CRP 59, I'm not sure what the reference range for CRP is.
Okay.
Glucose low, 3.5, 3.4, it's a bit low. Sodium 131 low, potassium high, urea, I think urea is elevated.
Okay.
So what's the most likely reason for this patient becoming unwell? So we have the electrolyte imbalance and the low glucose. Let's see, she's hypertensive, polymyalgia, and asthma.
So once again, in this history, everyone go in, underline in this history, there's a few things that are quite important.
Polymyalgia. So she's probably on steroids.
Yeah, okay, excellent. Yeah, polymyalgia rheumatica. Normally we
Yeah.
take steroids for that, right?
Yeah.
So this person's been taking
Yeah.
chronic steroids,
So,
and straight after operation, now she's becoming unwell. There's some sort of stressor involved, right?
yeah. Yeah. That's, I've forgotten what that condition is called. When you take, is it Addison's? Yeah. I think
Yeah,
it's
yeah, you definitely
Addison's.
yeah. So in this
Yeah.
case, yeah, E, definitely.
Yeah.
So this is a patient who's come in with a chronic use, polymyalgia rheumatica. You'll be taking like prednisolone every single day. Some of them take it for like 10, 15, 20 years, especially when you're diagnosed. Most of these people are diagnosed around later ends of life, so around 70s-ish. So they'll be taking a steroid every day. And especially now, this patient's been taking steroid every day. They've gone in for an operation. What do we say normally the rule is for a person that has Addison's disease and they go in for an operation? What do we normally do?
Stop.
I think you increase the
Yeah, you increase,
or
yeah, absolutely. You increase the steroid requirement. Why? Because surgery is a very big stressor on the body. And so you need those steroids to end up helping you through that phase. So definitely we give, in that case, we definitely give extra steroids. And just like you said, Dr. Ruth, this is Addisonian crisis. And when you look at the blood test, you can see that classic high potassium, low sodium, and once again, that history of steroid use, just like you said. Excellent. Thank you, Dr. Ruth. We'll get Dr. Pauline Batuza, please.
A 46-year-old man comes to see you complaining of feeling more tired than usual. He is worried that he may have developed diabetes like his father. You order a set of blood which show a HbA1c of 45. Which one of the following is the best course of action? A, discuss diet and exercise. B, start metformin, 1 gram BD. C, start metformin, 500 BD. D, reassure and advise, repeat in 6 weeks. And E, refer to the endocrinologist. Shoot, this is not the unit I use.
That's okay. What do you think is, what are you getting? What does that feel like, that unit? 45 millimoles.
HbA1c of 45. Is that
Sorry?
not as high, I guess?
Okay, okay,
I know
it's not as
6% and the percentage wise is 6%.
Okay.
Around that range, but
Yeah.
I've forgotten that you.
So I think from what I remember, if it's above 48, we consider it diabetic. If it's below 42, we say it's like you're absolutely fine. There's no diabetes involved. This sits somewhere in that sweet range.
In the middle.
So in that case, what would this person be?
Yeah, so it'll be impaired glucose tolerance.
Yeah, well, we wouldn't know, but we know that this is some sort of pre-diabetes, right? It could be impaired glucose tolerance, or it could be impaired fasting glucose, right? We'll only know after we do an OGTT. So in that kind of patient, what do you recommend? What's the advice we give? What do we do? What's the management?
Yeah, I would yeah, I think you'd start with diet and exercise. And I think you repeat the test in a year or so.
Absolutely correct. Yeah, you repeat your HbA1c in a year or so. So once again, these pre-diabetes, it's a reversible state. So if the patient's able to, general advice is to drop about 7% body weight. If you can do that, then the chances of you developing diabetes are much better. And you can end up preventing that onset. But once again, once you're diagnosed with diabetes, you're diagnosed with diabetes. You can't change that. Yeah, definitely here. So this patient is once again sitting in that pre-diabetic range between 42, 48. And so they're pre-diabetic at this point. We don't know if it's impaired glucose tolerance or impaired fasting glucose. The only way to figure that out is after we do the OGTT test. But yeah, this is the slide that we had from our last one. So yeah, normally what we say, reduce your body weight by about 7%, increase your exercise, and then test them again in a year. Usually the case is within, I think, I can't remember the statistic. If they continue being pre-diabetic for 3 years, the likelihood of them getting diabetes is almost, I think it's 3 to 5 years, they'll end up developing diabetes if they do not make any changes. So if they continue down this way, within 3 to 5 years, they'll be diagnosed with formal diabetes. And this is a lovely, lovely, lovely chart that we had. Excellent. Dr. Misha, please help us.
Yeah, Dr. Omar,
Yes.
question before we do
Yep.
this one. Yeah, do we need to know the different units? Because like, why don't
Yes.
they stick to one
No,
HbA1c
yes.
like
I'm so-
percentage?
yeah. There's no way around it. Yes, you'll have to learn both units.
Okay.
Sorry, like I wish it was easier. And I said, no, usually they only use percentage or no, but no, they can choose either or. It doesn't matter. I know a lot of us are very, very comfortable with the percentage units. Even me, I think I don't really remember the millimoles very often. I just look at the percentage because it's funny because most of the recommendations by the Endocrine Society is given in percentages as well.
Yeah.
And even
Okay.
for us, when we write it, we check the HbA1c, we just do it in percentage. But millimole, they can give you the millimoles per mole. This whole chart, both units, this is by the RACGP. This is what we
Yeah.
write. So sorry.
Okay.
Who was I going to ask? Dr. Misha, please.
A 72-year-old man presents for review. His medical history includes type 2 diabetes mellitus and gout. 6 months ago, his blood pressure was 144/84. We gave him basic lifestyle advice and advised him to come back 6 months later for a quick blood pressure check. 3 further blood pressure readings have been as followed. Priscilla, his current medications include metformin and endocrinology. What is the most suitable management of his blood pressure readings?
So this is more of a cardiology question. So I'm just putting them out there. This is a cardio question, but it is related to diabetes. So I'm sure you guys have already covered this in cardio, but I think, yeah, this is also a very related question. So please, Misha.
So the options are stop the allopurinol, start therapy if 10-year cardiovascular risk is greater than 20%, continue lifestyle measures into you in 6 months, start binge of methazide, start an ACE inhibitor. Well, basically, he is beyond normal level of VT. So because he failed lifestyle changes, we kind of need to prescribe some medications. And I think the best option could be ACE inhibitor, which can be the one that lowers
I agree with you. I think ACE inhibitor would be definitely recommended here. So if you, once again, if you look at the history, the thing I want to point out to you guys is that this is a person with type 2 diabetes. If, example, in this, they wanted to give you a CCB now, would that change your options? Probably, yeah. Typically, people who are type 2 diabetes, we end up going with the ACE inhibitor, preferably, over a CCB. If they're over the ages of 55, less than 55, people who are typically of Afro-Caribbean or African descent, we end up choosing one drug over another as well. So yeah, as this man has type 2 diabetes, we typically go for an ACE inhibitor. That's usually the case. If they don't have type 2 diabetes and they're usually under the ages of 55, we can also go for a CCB. That'd be a better option for that. Okay.
Sorry, Dr. Can I ask you a question?
Yeah, sure.
For the previous question, do we also get like a table that risk? I'm not sure, the one with the different yellow.
I know exactly what you mean. It looks yellow, looks red, looks blue, all that color. Yeah. So another thing I want to point out here, anyone who's type 2 diabetes, they are considered high cardiovascular risk, regardless of age or regardless of smoking, non-smoking status. Because if you look at that chart, the chart is divided into 2 or 3 things. One is by gender. Is it male or female? The second thing is divided by smoking, non-smoking. And the third is diabetes, non-diabetic. When you are diabetic, you automatically fall into high cardiovascular risk straight away. That will probably be covered more in your public health lecture, but it's definitely something I have seen come up on the exam multiple. I had on my exam as well, multiple times. But the good thing is you don't need to memorize the chart. You'll just know how to read it. That's all you need to do on the exam. But then remember that there are a few things that kind of straight away, I think if you have diabetes, straight away you're considered high risk.
Sorry for this question and metformin. Contradiction is a cardiovascular disease, and also can this patient still use metformin because
Sorry?
blood pressure is high?
Well, it depends. What are you trying to treat? A metformin is normally treating for the diabetes, right? This patient may already be on the diabetes, but the question here is asking, how do you treat the blood pressure, right?
Yes. I'm asking other question. For example, here, and also the contradiction for the metformin, and also it's a cardiovascular disease. Is that right? Or in
No,
this case,
from what I remember, the
defined.
main contraindication for metformin is creatine clearance. If you have if you have the creatine clearance of less than 30, you consider stopping. If it's less than 15, absolutely stop. Why? Because we're scared of lactic acidosis as a complication.
Okay, thank you.
Yeah, no problem.
Dr. Omar?
Yes, Dr. Fry.
On the same question, given the stem, right, of the answers given, I guess the ACE inhibitor will be correct, will be all correct here. But the question I have here is, this patient is diabetic, that's okay, and is got gout, and is taking allopurinol.
Okay.
If I remember correctly, typically we would want to give ACE inhibitors with allopurinol because it increases the chance of getting hypersensitive reactions like SJS. So more often than not, typically we go for ARBs like losartan, particularly losartan, because it's so I don't know. I'm just wondering, in real life, would you give an ACE inhibitor given the patient is on allopurinol, or we just go for an ARB?
Yeah, typically, like I've been like this, like my whole term right now. I've just finished a whole cardiology term. You would be surprised the amount of people who come in with gout and at the same time are on some sort of ACE or ARB. We prescribe it very, very often in practice. Like I've seen hundreds and hundreds of patients, and I've seen dozens of them with gout, and we still give ACE and ARBs. I think it's once again one of those kind of thing where we get very, very scared of in literature, like the whole SGLT2 40 is gangrene. It doesn't really happen, but it's something that we know about, but it's something in practice that we don't really have issues with.
So, thank you.
No problem. Okay, we'll go. Dr. Leiber, could you help us with this question, please?
A 38-year-old female presents to the GP as she has been feeling generally unwell for the past 2 weeks. She explains that she's often hot and sweaty and is struggling to sleep at night. Her husband has also noticed she is unusually agitated and is on the edge a lot of the time. She has no past medical history of note, but states that she was unwell with flu-like symptoms around 6 weeks ago, which has since resolved. On inspection, there is goiter that is tender to palpation. The thyroid function tests are ordered and returned as follows. TSH is 0.5 and T4 is 21. Given the most likely diagnosis, which is the first line of management. Carbimazole, conservative management with ibuprofen, propylthiouracil, and radioactive iodine therapy, thyroxine. So the T4 is raised.
Yep.
And TSH is in the normal limit, but borderline low. So,
and this history, tell me anything. Oh, Dr. Albert, thank you. Absolutely. Dr. Albert pointed out something very, very, very important. This person was unwell about 6 weeks ago. And what are these symptoms that they're presenting with?
Like hyperthyroid.
Remember everything agitated, sweaty, anxious. These are all hyper symptoms. And your TFTs actually show that right now. You have elevated T4s, right? So this is definitely hyperthyroidism. Another thing, I don't know who's using the purple marker. Absolutely correct. Tender on palpation.
Thyroiditis.
So there was a condition that we talked about. I haven't seen you in the last couple of lectures, but this is a condition that we talked about previously twice. Tender goiter, hyperthyroidism, recent flu. What does that bring?
Subacute thyroiditis.
Okay. Yeah, the other fancy name we used was?
They're curving, Dairy
Yeah,
Queen.
curving. And the best way of managing it is just conservative, right? Why? It is a transient disease. You get hyperthyroid, hypothyroid, and you get resolved. Absolutely correct. But yeah, this is, once again, if you ever see like a tender goiter and you see hyperthyroidism and you see illness, that's my triad. As soon as you see that, I'm like, that's good enough for me. Excellent. Thank you, Dr. Leiber. Dr. Igor, please. Questions for
Hello.
you. Hi.
Okay, a 28-year-old woman is seen in the endocrine clinic with the results of the thyroid function test shown below. For the preceding 2 weeks, she's been suffering from palpitations, excessive sweating, and unintentional weight loss. On examination, she has a notable thyroid goiter, which is tender upon palpation. And the question is, what is the most likely diagnosis? So thyroid stimulating hormone is 9.4, which is elevated. Free thyroxine is 6.4, which is low, which is decreased. And options are A, follicular carcinoma, B, Graves' disease, C, Hashimoto's disease, D, papillary carcinoma, E, subacute decurvain thyroiditis. So given the history, the clinical presentation, we can see symptoms of hyperthyroidism, which is palpitations, excessive sweating, and unintentional weight loss. Also, we have physical examination, which is tender, which is the thyroid gland tender upon palpation.
Yep.
Which makes me think of the Korean thyroiditis as well. So yeah, I think it's subacute
Absolutely.
thyroiditis.
In the exam, they can be quite mean to you and not give you a TFT and just give you the history. So it's very, very important that you guys, once again, go through the question, understand what is important, what is not. But absolutely correct, Dr. Igor. Thank you. All right, next question.
Sorry,
Dr.
how can we distinguish it from Graves' disease?
Graves'
Only
disease.
Because of
Well,
eye?
once again, yeah. So this is a goiter. So Graves' disease, they'll either give you, they can give you serology, they can give you the TFTs if they want. At the same time, the expression is, they'll also have the symmetrical goiter. It'll be even on both sides. At the same time, they could also have eye disease. If you ever see eye disease, just straight away, if you think of eye disease, hyperthyroidism, go Graves straight away. There's quite a few that'll differentiate between it. Graves' disease, you'll also notice in people who are typically younger. You'll notice it typically in women of around middle age. And they'll also have some sort of other autoimmune linked condition as well. So there's a few hallmarks that can kind of indicate. This one, we know this is just because of an onset of some sort of upper respiratory tract infection. But in Graves, it's very, very indicative. There's lots and lots of different things to differentiate them.
Yeah, and also I'm confused that we have symptoms of hyperthyroidism, but T4 is low and TSH is high. I would expect low TSH and high T4.
Yeah. So definitely in the history, you've got hyperthyroidism, but on the labs, they should have been more specific and told you when these labs were taken. But typically later on in the labs, you get symptoms of hypothyroidism as well, right? Remember, you go through a biphasic model. You go hyper, and then hypo. So that's typically a picture of decurvain subacute thyroiditis. But yeah, you're right. The symptoms here are not very, very indicative of the labs. The labs are very hypo and the symptoms are very hyper. But you're absolutely correct. It all matters when you take a picture of this disease. If you take a picture of it in the first couple of 6 weeks, you'll get a hyper picture. If you take it at 6 weeks, it'll be you. And then about after 6 weeks to 6 months, it can be hypo. So, yeah. Thank you, Dr. Misha. Dr. Albert, next questions for you, please.
All right. A 72-year-old man attends his annual diabetes review, having been diagnosed with type 2 diabetes for mellitus 4 years ago. Patient takes metformin 1 gram twice daily and glycoside 160 milligrams twice daily. He has good medication adherence. His most recent A1C is below. So A1C is 60 millimole, which is super high. The nurse decides that the patient needs an additional anti-diabetic drug and prescribes empagliflozin, 10 milligrams once daily. What side effect is he most likely to experience? Diarrhea, risk of bladder cancer, risk of UTI, peripheral edema, weight gain. So the way I try to remember this is empagliflozin, it tries to excrete the glucose by flowing it up, through
Yep.
the urine. So
Absolutely.
increase risk of UTI because there will be more glucose excreted through the urine.
Excellent. Yeah, absolutely correct. Yeah, SGLT2, right? We said SGLT2, one of the main complications. It's very, very interesting. But when you prescribe an SGLT2 to any patient in Australia, you have to give them education about it. One of them is the same thing. If you say, oh, if you get UTIs, you're going to have an increased chance of UTIs, or if something happens and you have some sort of kidney injury or kidney disease, you have to stop this temporarily. So there's a whole bunch of education that goes around, and people are pretty compliant. They're pretty okay with it. But absolutely correct. What is this increased risk of bladder cancer? We talked about a certain drug. Does anyone remember?
Glitazone.
Yeah, the glutazones, right? They have an increased risk of bladder cancer. And who are they contraindicated in? Which patients we
with heart
absolutely,
failure.
yep, heart failure, absolutely correct. Anyone in heart failures, if you see any, like we saw the handbook question, the example they gave in the handbook, that patient had heart failure. So straight away in that case, we know definitely we're not going with any sort of glutazones. And what was the most common side effect of someone taking metformin?
GI effect?
Yeah, GI
Most.
upset. That's GI upset. So once again, if the patient comes in and the question's showing you that this patient's come in, he's complaining of GI upset as his main issue, and they ask you what is the most likely agent causing this, you know, probably metformin. Excellent. And the weight gain, do you guys remember which ones? There was a few drugs that did it.
Sulfonylureas.
Sulfonylurea is definitely one of them. And the other one was?
Oh, I forgot.
No, it's okay. Absolutely. It's an open question. Anyone can answer it. Just even taking
Metformin?
insulin. No, metformin doesn't really cause weight gain.
No,
Prednisolone?
gluconides and insulin.
Insulin, yeah. Insulin is the main one.
Insulin.
Very, very important. Insulin, remember, insulin and sulfonylureas work very, very similar. Sulfonylureas just cause your body to excrete more endogenously made insulin. Whereas if you give someone insulin, they're bringing it through an exogenous source. But absolutely, weight gain is one of those problems. And which one was the drug, the magic drug that we use for weight loss?
Ozempic.
Okay, on the exam, they're not going to say Ozempic. I need to be more specific here.
GLP-1 agonist.
Yes, GLP-1 agonist.
GLP-1 inhibitors, yes.
There you go. I wish it was that easy. Just say, oh, it's Ozempic. Everyone would know the answer, I think. All right.
And doctor, we have to.
Yes.
We have to learn all the names, commercial names of SGLT.
No.
SGLT.
No, I don't even know the commercial names. We just call them DAPA or Pia, whatever. Like, you just need to know the pharmaceutical names. Don't need to know the brand names for them. The only brand name you might need to know is like Panadol or aspirin or something like Advil, maybe. Those kind of very generic ones. But you don't need to know the brand names. All right. I'll ask you, Dr. Amina. Did you want to give this question a go?
Yes. So, a 68 years old woman is found with a decreased level of consciousness at home by a neighbor. She has past medical history of dyslipidemia. She is on atorvastatin regularly. She lives alone and is a retired healthcare assistant. She is brought to the emergency department via ambulance. On arrival, her observations are high temperature 33, heart rate 43, which is low, blood pressure 82 out of 48, respiratory rate 12, and oxygen saturation 93% on air. On examination, she is cool to touch. Her Glasgow coma scales is 8 out of 15. Chest auscultation is normal. She has normal heart sounds and no murmur is audible. There is no peripheral edema. Abdominal examination is unremarkable. She is resuscitated initially with intravenous fluids, antibiotics, and oxygen is administered. Despite this, she remains hypotension and bradycardia and hypothermic. So her oxygen saturation are 96% on
So
low
I know it's a long
low
test.
sodium.
Yeah. What do you
Mhm.
think the condition is? What do you think they're trying to fix?
They try to fix the blood pressure because she is in shock, I think.
What's the diagnosis that you have now?
Here,
If you look at if we just look at the labs, you can see your TSH is very elevated, and your T4 is 1.3, which is extremely low. They have altered mental status. This is kind of it kind of makes you think, yeah, hypothermia, low heart rate, low blood pressure, low respiratory function. There's a lot of lows going on, right? So what do you think this condition is?
hypothyroidism, myxedema coma.
Okay, yeah. So what was the condition? How do we treat that normally?
I think anti-steroid hormone replacement with I don't know if we have to give her noradrenaline or cortisone, hydrocortisone.
In this one, it's cortisone, right? Always there with a staple treatment for myxedema coma, it'll be fluids, IV replacement, and hydrocortisone. And 100% at the moment, this person's unstable, they're hemodynamically not stable, we always go IV. As soon as they become hemodynamically stable, we can switch that to PO. So keep that in mind. Some of the options, they might have two of the same options, but just be very smart and look at what they're giving it in. Sometimes they'll write IV, sometimes they'll write PO. In this patient definitely cannot take anything per mouth. Yeah, great job, doc. Long-winded explanation, and I'll get Dr. Who have I not asked? Oh, there's all the hidden ones. Okay. We'll go back to the top. Dr. Nitin, quick, easy question here.
All right, so 45-year-old man presents to ED. He's described severe muscle cramps for the past day, alongside muscle weakness, aching. He's currently experiencing homelessness. Okay. On examination, he has central obesity, round puffy face, visible strainous abdomen, Cushingoid features. Heart rate 82, respiratory 12, blood pressure 190, temperature 37, saturation is 9, diagnosis of Cushing's is suspected. Plasma cortisol is sent off along with other blood tests. A VBG is taken. What would be expected? Hypokalemic metabolic acidosis, hypokalemic metabolic alkalosis. Oh, okay, so it's hypokalemia definitely.
Okay.
Yeah, all the excess of cortisol, it's going to cause sodium retention, it's going to release potassium in exchange out of the body.
Okay.
And yeah, there's some relation to cortisol and hydrogen ions, probably. Yeah, I guess alkalosis, that's probably inverse.
Okay, what about everybody else?
Yeah, it's B. Okay.
Yeah, I'll give everyone about 5 seconds. 3, 2, 1. Yeah, this one. It is B, absolutely correct. So And this has actually come up in the past as one of the exam questions, except they made it a bit more difficult where they didn't give you the other options. Only one of them was hypokalemic metabolic alkalosis. The history was telling you that this is some sort of Cushing's disease. And they give you 3 or 4 other options that seemed also very correct. So this, yeah, it's very important, this one actually. This is a whole long-winded explanation. If you want to understand why the relationship between the sodium, potassium, and the hydrogen ions are, it'll tell you there. Dr. Albert, please help us.
Help me. A 38-year-old woman comes to the clinic. She's usually fit and well. 6 months ago, she had a significant weight gain around her midriff, but no lifestyle changes. Right. Her friends have noticed a hump on her upper back and increased transverse diameter of the face. She's worried about reduced exercise tolerance and fatigue. Climbing stairs makes her thighs ache, and she struggles to get up from the sofa. She takes no regular meds. Investigation, so 9 a.m. plasma ACTH is normal, 9 a.m. serum cortisol is high, and 24-hour urine cortisol is super high. So what's the most appropriate investigations to carry out next? All right, so high cortisol but low ACTH, which means ACTH is not responsible for the high cortisol. So with this. Yeah, I think I'm gonna go with the others, see how the upper organs are doing, and do CT.
Absolutely correct. Yeah. Once again, we have different tests that test midnight cortisol levels. We don't do that. We do morning cortisol levels. OGTT, we do that for other tests that we'll talk about today. Adrenal vein sampling is also something that we can do, but it's something that we do much later on. And the short synaptin test is what we use to typically test for ACTH levels. So over here, yeah, this is very Cushing-Goid syndrome. It's got all those very, very classic symptoms of Cushing's disease, right? Yeah, but in this case, the best way to probably do CT just to identify, what this patient is having, where the problem is. That's a good imaging to go with. Once again, this is the little pathway that we talked about before. We can do how we kind of go down. We go Cushing's, ACTH, which we've done. We go high dexamethasone suppression test, and then you can go down and do CTs there. Excellent. This is a past exam question. I'll get Dr. Farai to get this one to go, please. This, I believe, came up in October last year.
A 9-year-old boy is admitted with diabetic ketoacidosis. He has no previous diagnosis of diabetes. The patient is treated with IV sodium chloride and a fixed rate insulin infusion and quickly recovers. On the pediatric ward, the diabetes consultant speaks to the patient and his family, explaining he has a new diagnosis of type 1 diabetes mellitus. The patient is started on insulin based on bolus regimen. He is discharged once he and his family are comfortable with the regimen. How often should the patient monitor his blood sugars as minimum? So 4 times daily before meals and before bed, once daily before administration of long-acting insulin, only when he experiences symptoms of hypoglycemia, 6 times daily before and after each meal, 3 times daily after each meal. I remember this from one of the slides last week. So the patient has been discharged recently, so you need to make sure that they check their pre and postprandial glucometers at least, and so you need about 4 times daily before meals.
I'm very, very, very happy and glad that you remember that slide. Absolutely correct here. You're absolutely spot on, Doc. Yeah, it's 4 times initially. This person's recently been diagnosed. This is the actual plan that we give. So initially 4 times a day before and after meals at first. Then we can do that twice a day. Then we can eventually do it 1 to 2 times a week. That's a person with type 1 diabetes. Type 2 diabetes is slightly different, but twice a day. And then if it's good control, 1 or 2 every week. Yep, but absolutely correct. This is an actual past exam question. So it's very, very important that you guys know how to actually do this and how to screen it. Excellent. Dr. Paulina, do you want to give this question a go?
A 40-year-old man was found to have elevated blood pressure. pressure of 165/102, monitoring by his general practice. The results showed his blood pressure was higher than 150/95 most of the time. He was started on Rami for the past 4 months. However, his blood pressure still remains elevated, and he occasionally complained of leg cramps. His blood test results were as shown below. A CT scan of his abdomen shows bilaterally enlarged glands. What will be the next step in management for this patient? So sodium is okay, potassium is low, bicarb is highish, urea is fine, renin is low, and aldosterone is high. So it's aldosterone is high. Yeah, so what will be the next step? So the adrenals are bilaterally enlarged, so you can't remove them. So the drug management, which we go with, yeah, spironolactone.
Okay, so what was the diagnosis?
A bilateral adrenal hyperplasia. Is it?
Absolutely correct. And in this case, yeah, the CT is kind of telling us that this is bilaterally seen. So the best way to manage is spironolactone. Now, if I told you that you see hyperechogenicity on the right adrenal gland, a solitary nodule on the right adrenal gland, what would you want to do?
They've removed that nodule.
Yeah, you just remove it. It's like Conn's disease, right? Typically. So you have some sort of aldosterone releasing tumor, you just go in and remove the tumor. Excellent. Good. How many? Okay. We'll do Dr. Igor, please.
A 58-year-old woman attends an appointment with the diabetes nurse after she was recently diagnosed with type 2 diabetes. Her recent HbA1c was 59 millimole, and the repeat test 2 weeks later was 61 millimole. Okay. She has a history of stable angina and essential hypertension. Her renal function was as follows: eGFR 72 and urine albumin creatinine ratio 2.3. What is the most appropriate initial therapy for this patient? A, start on SGLT2 inhibitor first and metformin, and titrate upwards as tolerated. Start both metformin and SGLT2 inhibitor immediately and titrate the metformin upwards as tolerated. Start metformin and titrate upward as tolerated. Add a DPP4 inhibitor or pioglitazone or a sulfonylurea if adequate glycemic control is not achieved. Start metformin first and titrate upwards as tolerated. Add an SGLT2 inhibitor if adequate glycemic control is not achieved. Start metformin first and titrate upwards as tolerated, and SGLT2 inhibitor regardless of glycemic control. I would go for the last option, because I remember that from the last lecture. And I remember that SGLT2 inhibitors are good for the decrease of cardiovascular risk and also renal risk, because we have decreased GFR 72, so we should.
Yeah, no, absolutely correct. SGLT2s, remember, I think Dr. Farai said this last time, we give 4 drugs for heart failure, right? One of them are SGLT2s. They are very good for the heart. So in this patient who's got this essential hypertension, stable angina, giving an SGLT2 will both take care of the diabetic sugars and at the same time will look after his heart and reduce the cardiovascular disease in the future.
Exactly, yeah.
Thank you so much.
I wanted to say.
No, you said it. You said everything I would say, actually. So, no, absolutely correct, Dr. Igor. All right. Dr. Nitin, please.
A 72-year-old man presents to his GP worried about his blood pressure. He has been measuring it at home, which results consistently above 140/90. Clinic BP shows a blood pressure of 161/101. He has a past medical history of type 2 diabetes treated with metformin and gout. Okay, so the urine dipstick and fundoscopy is normal. He denies any other symptoms. He's of Afro-Caribbean origin. So, history of diabetes, Afro-Caribbean origin, and hypertension. ACE inhibitors, and we don't have them. And ARBs, well certain. Yeah,
Everyone
any
else, I'll
one
give
of
you guys
those.
10 seconds. 3, 2, 1. Yeah, in this case, ACE ARBs. Remember diabetes, hypertension. I want you guys to think ACE and ARBs. That's the first line we always go with. It's really, really good. If they don't have diabetes and they're on Afro-Caribbean descent, then typically we can end up opting for CCBs, which is quite interesting. It's more got to do mostly with genetics. For some odd reason, people of African or Afro-Caribbean descent don't efficiently, the ACE inhibitors don't work as efficiently as people of other descents, oddly enough. It's very, very similar to when we have people of Asian descent when it comes to ethanol metabolism. People typically of like China, Japan, Eastern Asia don't process alcohol very, very efficiently as opposed to someone of like African, Caucasian, anywhere else in the world, right? It's just in terms of genetics, that's just what it is. Excellent.
Also, there's an increased chance of angioedema with ACE inhibitors compared to ARBs in Africans and patients of African descent.
That is true too.
That's the reason why we go for ARBs. Yeah.
Absolutely. So that was the little summary class that we had. I hope a lot of these questions weren't too difficult and pretty easy. I'm sure all of you guys killed it. You might as well get through that way too fast. Now, when it comes to our lecture today, good news, we're at the end of it. So we haven't got long to go. We're at the end of the race. You guys have covered a lot of endocrinology. So this is the ending. Good thing is it's not a big lecture. It's very short, but we're just going to cover those little small miscellaneous topics along the way. Index. This, I promise you, there's no surprises here. It's as simple as it looks. Today, it's going to cover pituitary adenomas, acromegaly, SIADH, diabetes insipidus, hypopituitarism. We'll cover a few endocrine tumors, and we'll cover electrolyte disturbances, especially what they look like on an ECG. Beautiful. So pituitary diseases, pituitary disorders. We've looked at the same photo. I put it in the first lecture. I put it in the second lecture. I put it on the third lecture. The reason is it's important. It's really, really important, especially this little part here, what happens in the front and what happens in the back. When we look at conditions today like SIADH or diabetes insipidus, those will typically affect the posterior pituitary. When you have issues and diseases like hypopituitarism, where you have a certain adenoma or an apoplexy or some sort of infarction, depending on where it is on the pituitary and how big it is, those are the symptoms you're going to get. So that's why it's very, very important to remember what comes from the front, what comes from the back. If you look at the anatomy of the pituitary gland, you can kind of see this little P-like structure at the bottom, and the thing just on top. Let me get a little, yeah. You can see this little region over here. That's your stalk right here. That's the part that ends up happening. Now, depending on tumors, sometimes you'll have tumors that happen up here and push downwards. Sometimes you'll have a tumor that starts here and then comes back up. And then you'll see how they have certain different symptoms and certain different presentations. Another thing that's very, very, very important is right in front of it, you have the optic chiasma. Does anyone, you guys have all done ophthalmology? Yes? Now the optic chiasm, what's so important about it?
It causes compression and causes bitemporal hemianopia.
Absolutely correct. Absolutely, 100%, doctor. So the nerves will end up going over here, and imagine if you have a tumor. You have, I'm terrible at drawing, but sorry guys. Let's say you have a little nerve that goes over here and goes around. If there's a compression and there's a tumor that's large enough over here, what'll end up happening is it'll end up causing something called a mass effect. If you guys play games, you guys will know that's an excellent game. But other than games, it will also cause these obstructive and compressive symptoms. So it'll push onto this optic chiasm, onto the optic nerves, so you will get visual disturbances. Okay. That's the general anatomy. We've seen all the time. You have the hypothalamus sends signals down to the pituitary. The pituitary will send signals down to whatever organ is acting, right? Excellent. So now we're going to start off our lecture with a pretty easy topic here. It's just pituitary adenomas, and then we'll talk about another condition called acromegaly. So pituitary adenomas, how do we differentiate them? We typically go down two ways, either they're functional or they're non-functional. Very, very, very similarly, how we looked at nodules in the thyroid, remember? We said we had non-functioning thyroids, which are our cold nodules, and then we had hot or functioning thyroid nodules, right? Which one had more higher levels of cancer or higher risk of cancer was associated with?
Cold.
Yeah, cold non-functioning, absolutely, yeah. Hot or typically hot or functioning nodules aren't that problem, but once again, that's just a question. It has nothing to do with this, but we just categorize them based on functioning, non-functioning. Prolactinomas are the most common type of pituitary tumor that we see. About 50% of tumors in the pituitary gland are prolactinomas. Clinically, non-functioning pituitary adenomas make up about 30% of the cases, so 50% prolactinomas, 30% non-functioning tumors. And pituitary adenomas are defined by size. That's another way we do it. So we do it by function, non-function, and we do it by size. So if they're less than 1 centimeter, we call them microadenomas. If they're between 1 and 4, we would call them macroadenomas. And if they're more than 4, we would call them giant adenomas. So one, we differentiate them on the size, and two, we differentiate them on the testing. When we do biochemical markers, and we look at serology and we look at blood tests, that's another way to see what they are, right? The biochemical testing is used to determine the function. Example, it's to confirm or to exclude both hormonal hypersecretion or hyperpituitarism. So if you look at your thing and you say, wow, there's a lot of growth hormone being released, you think, okay, this is a functioning adenoma. However, if you do something called a triple test and you see everything is low, right? Your growth hormone is low, your prolactin is low, your TSH, or all of those organs are low, we know that that's a non-functioning adenoma or a hypopituitarism because there's multiple hormones involved. We can also use radiology. Typically, we like to go with MRI. Anything that has to go with the brain, MRI is really, really good. Why? Because it is a very, 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 very small structure. Especially an MRI is going to be very good if we want to go in with surgery. We can identify the whole anatomy and we know exactly where to go. Imagine if you have a microadenoma or you have even if you have a macroadenoma, something that's about 1.2 centimeters big, that's this big, you have to somehow not screw up, go up the nose, go into the brain, and then make sure that you cut the right part out, centimeters difference. So you can imagine you need the most accurate imaging. MRI would be the best way to go. Excellent. So once again, we said functioning and non-functioning. So if we look at non-functioning pituitary masses, so the only reason these become an issue is because of two things. Either one, something called mass effect. So what happens is the effect is because of the size. So either the prolactinoma or not the prolactinoma. So the adenoma gets so large, it causes the meninges to start stretching. It's going to cause constant headaches. That's why you get headaches, and that's because of mass effect. It's because of the size. At the same time, if the tumor gets large enough and it pushes on the optic chiasm, you're going to have that bilateral hemianopia, bilateral temporal hemianopia. At the same time, if it's non-functioning, you're going to have you're going to have less actively functioning pituitary, if that makes sense. So you'll have signs of hypopituitarism as well. That's another feature. So you'll have mass effect, compression symptoms. At the same time, you'll have decreased functioning. Typically, these are not fast growing and then therefore can present after several years. Treatment is usually surgery, but we typically choose surgery for those kind of tumors that have gotten too large. Those are the ones that are causing mass effect. If they're small and stable, we can just monitor them. Once again, these are very slow growing. Some of these tumors may have been around for quite some time, a couple of years, and now they're causing problems. If they're still small, we just watch them. If they're macroadenomas, once again above 1 centimeter or more than 4 centimeters, we definitely want to go and operate. Some non-functioning tumors may behave aggressively, requiring more than one operation, or we can also use radiation therapy, but malignancy is usually rare. We've got a question here. We'll go Dr. Pauline, sorry.
44-year-old woman presents with a 3-month history of nipple discharge. A systematic inquiry was otherwise unremarkable. She has a past medical history of schizophrenia, for which she takes olanzapine. She also states that she smokes cannabis on a daily basis. Her blood results are as follows. TSH is normal, T4 is low, prolactin is pretty high, estrogen is low, LH and FSH are low. What is the most likely cause of nipple discharge in this patient? So her okay, so her leptin is high. She's on a drug for that, so that's what's confusing.
Okay.
Okay, so her I'm trying to figure out. Okay.
I'll give everyone about 10 seconds to pick an answer. But I can say, you can tell, like, this is slightly confusing, isn't it? Everyone's schizophrenia, olanzapine, a lot of things are very low. Prolactin's elevated. Is that normal? Is that not normal? All right. So in this case, it's actually a non-functioning pituitary adenoma. Oddly enough, right? Scary. Yeah, that was a bit of a curveball there. So yeah, in this case, it's a non-functioning pituitary adenoma. It's a result of this pan-hypopituitarism. Once again, everything was very, very, very low. When you do have compression of the pituitary stalk, you can get hyperprolactinemia. That once again happens due to a decrease of that dopamine. I'll explain this more in depth in the next lecture, in the next slides. But it happens due to a decrease of dopamine from the hypothalamus to the pituitary. Dopamine acts to suppress prolactin release. Thus, the non-functioning pituitary adenoma accounts for a biochemical uptake. So essentially what's happening here is, I'll give you this little tip in the future slides. But if you have a prolactinoma, you will have very, very, very elevated prolactin in the thousands, not in the hundreds. Dopamine, the other name for dopamine is actually prolactin inhibiting hormone. It actually stops the use of prolactin, inhibits its effect. So what ends up happening here is because there's decreased levels of dopamine, that prolactin ends up going up and there's no inhibitory action happening either. So that's why, and typically when there's compression of the pituitary stalk, you also get an increase of prolactin. Now, let's go on to prolactinomas. Now you guys will see a very, very clear difference. So when it comes to prolactinomas, these are the most common type. We said about 50%, remember 30% are non-functioning. And what happens is essentially these are prolactinomas. These are masses that secrete excess amounts of prolactin. So one interesting relationship I mentioned briefly is dopamine actually inhibits prolactin. So dopamine, the other name that we actually call is prolactin inhibitory factor. So when you have very, very high levels of dopamine, you'll also notice that it'll decrease prolactin levels. And that you'll see when it comes to the management of prolactinomas. It's actually things like cabergoline, or we can give dopamine agonist because that inhibits prolactin. That's one of the ways we can treat it. Now, prolactinomas, what are the causes? One is pituitary stalk damage. Once again, if there's pituitary stalk damage, there's going to be decreased dopamine, so there's nothing inhibiting prolactin release. We can, of course, once again, we have drugs, antipsychotics, various antidepressants. We have that classic risperidone, olanzapine, those antipsychotic drugs that we treat schizophrenia from. If you guys do M+6 or Ambidex, you would have seen hundreds of those questions. We think about drugs like metoclopramide, cimetidine, estrogen, opiates, marijuana. Physiological causes could be pregnancy and breastfeeding. Of course, we know during pregnancy and breastfeeding, our body is in the need of prolactin. Why? Because prolactin actually helps with glandular development in the breast and helps make all that beautiful milk. So that's why you end up having these prolactinomas. And when a person is pregnant or they are breastfeeding, the prolactin will naturally be high. Now, when it comes to the features or the presentation, if you understand the pathophysiology, it'll be very, very easy to remember. So when it comes to men, you're going to have that classic impotence. Why? Prolactin actually inhibits spermatogenesis. So you will be harder. It'll be much, much harder for a man to conceive. You'll have that impotence. Same time, you'll have that loss of libido. You'll have galactorrhea and gynecomastia. Why? Because at the same time, if it's prolactin, you're releasing excess amounts of prolactin, that's going to go and act on the glandular tissue in men as well. Men also have glandular tissue. 99% of breast cancers happen in women. That's the actual number. 1% happen in men. So men can still get breast cancer. Why? Because men still have glandular tissue, breast tissue. So a person, especially if you see that classic thing where you see antipsychotics, you'll see a lot of people end up developing gynecomastia or galactorrhea. So in this case, that extra prolactin will help develop the glandular tissue. At the same time, you'll get erectile dysfunction. In women, very, very interestingly, you get amenorrhea. Why? Because prolactin actually inhibits FSH and LH, so you get no ovulation. If you think about it in pregnancy, for example, when a person is pregnant, there's a reason they don't get periods, is because there's excess levels of prolactin that's actually inhibiting your ovulatory cycle. FSH, LH will be decreased. You'll become infertile. Once again, no FSH, no LH. So you're not going to have ovulation. You're not going to have that development. Galactorrhea, same thing as men. Osteoporosis. So why? Because there's no FSH, LH, you'll have decreased levels of estrogen, which end up increasing osteoclast activity. So you'll get that classic back pain, you'll get that bone pain, all of those things. You can get headache. Once again, these have got to do with the mass effect. So you get headaches. Why? Because the mass is so large, it's stretching the meninges. You can get visual disturbances, just like Dr. Sirat said, that bitemporal hemianopia. So bitemporal, the temporal side, you can't see. So vision field is lost. You can also get upper temporal chondroitinopia, symptoms and signs of hyperpituitarism. Excellent. Yeah. I'm just trying to read notes. Yeah. So same time, the anterior pituitary, you have something called lactotrophs. Those lactotroph cells are the ones that actually end up secreting prolactin. And at the same time, you have the gonadotrophin cells, which end up secreting your GnRH. They will end up going and secreting all of your other FSH, LH hormones at the same time. But prolactin ends up inhibiting both of them. And prolactin also has an inhibitory effect, negative feedback, where it goes back and stops that whole cascade. Excellent. Now, this is a little tip for the AMC that I have used myself, and I say it all the time. So when it comes to how do we diagnose this, always exclude other states for increased levels of prolactin, so things like pregnancy, lactation, hypothyroidism, and medications before we start doing the working up. How do we test it? Serum prolactin and microprolactin assays. Now, typically, here's the tip. So serum prolactin, if it's less than 2,000, it's suggestive of a tumor. It could be a microprolactinoma or a non-functioning microadenoma of the pituitary stalk, just like that first question that we saw. Everything was decreased in that, right? So we had that pan hyperpituitarism. Everything was low. Prolactin is high, once again. Why? Because dopamine is not being secreted to stop that prolactin increase. If you see that the prolactin is more than 4,000, think of a macroprolactinoma. For the sake of the exam, this is a little exam tip in AMCE. If the normal level of prolactin is usually lower than 400 millunits per liter, a very high prolactin level, more than 5,000, usually means that there's a prolactinoma present. But if it's less than 5, still elevated, but less than 5,000, think of other causes like drugs. So when you're worried about risperidone or olanzapine or all those antipsychotic drugs that are notorious for causing prolactinomas, if it's less than 5,000, it's still elevated. If it's less than 5,000, it's more likely to be a drug. If it's more than 5,000, most likely to be a tumor. That's a good way to differentiate. Another, once again, imaging, we're going to go for an MRI. Now, when it comes to the treatment of this condition, majority of patients with prolactinomas, we use dopamine agonist. Why? Once again, I said dopamine inhibits prolactin, right? So the most common one we use is cabergoline. We could use bromocriptine, but we don't use it because of the side effects associated with bromocriptine. Cabergoline is usually our first line. This normalizes hyperprolactinomas usually in 85% of cases and results in a shrinkage. I do want to emphasize, though, that there are cases where they are very resistant and they don't respond to treatment. In those kind of cases, what we can do is then at that point, we can go into surgery. But cabergoline is usually our first line. So in experienced hands, surgery can be considered as primary therapy for patients with microadenomas and for women with macroadenomas that want to get pregnant. But it's usually reserved for patients who are resistant to therapy or experience significant side effects. So cabergoline dopamine agonist is our first line. Now I've got a question here. We'll give this to, why not? Dr. Basira, please.
A 33-year-old woman presents to the general practitioner with her partner. Her periods have become less regular over the last number of months. This frustrates her as she has been trying to become pregnant. She also complains of frequent headaches. Otherwise, this woman is normally well and has no past medical history. She currently takes prenatal vitamins. She recently underwent a brain MRI scan, which identifies a large ciliar mass. Given the most likely diagnosis, which type of visual field defect is most likely to be present? It's bitemporal and superior quadranopia,
Why not inferior?
because I cannot explain, but the fibers
That's okay.
decussate, and the area where it compresses,
Mhm.
it contains the fibers from the inferior part, so it's
Okay.
give the defect of superior quadranopia.
That's absolutely correct. No, you said it absolutely right. That's how I would say it. Because it impinges, it presses on the bottom fibers, the inferior fibers, so you don't get vision in the top, right? Absolutely correct. It's a bitemporal superior quadranopia. In the last slide, if I didn't write that, it would be a little bit tricky. But do you guys remember how the optic chiasm forms and why you get different visual defects? I think for your exam, it's important for you guys to know, because depending on the vision loss, that is what presentation you'll have. So you will be able to identify where the lesion is depending on the depending on the vision that's being lost. So I'm going to draw a really, really quick chart. So if you look at I hope that kind of helps. So sorry for the bad drawings. So typically when you see your eye, let's say you have one eye over here. Typically you have one eye here, one eye here. What you'll do is you'll have two main fibers coming off on each half of the eye. So when it comes to drawing them, you'll have this half here that comes down and goes on this side, same as this one here, the lateral aspects. When it comes to the medial aspects of it, you'll see that they cross over like this. Now, if you have a pituitary tumor, the pituitary tumor would be sitting somewhere across here, right? So which of these, another thing that's quite important, when it comes to vision, this side sees over here, this side sees the nasal part, this side sees nasal, this side sees the outside part, right? Now, if you have compression of the stalk, which is in the center here, what fibers are going to be compressed and impinged? It's going to be your medial fibers, these ones, right? So when you have a compression over here and you start pushing down on these medial fibers over here, you start impinging on them. What's going to happen if you follow the blue ones? If you follow them up, they sit over here and they see the outside part. That's why this is no longer functioning. So you get bitemporal hemianopia. So on the outside, you're not getting this vision, right? That's why. That's why you get the temporal side. Now, why do you get the superior and the inferior side? So just like Dr. Basirat said, I don't know why. Let's see. Second. There's usually a good photo. Where is it? Yeah, this one will do. So can you guys see this photo here? Oh, God. Is this photo clear? Can you guys see it? Now, what happens is you'll notice the optic nerve, the chiasm, actually sits superiorly to the top part of the pituitary, right? Normally, if the tumor is over here, it's going to cause compression to the inferior half. When it causes compression to the inferior part of the optic nerve, you lose vision in the superior. Does that make sense? That's why you get the bitemporal superior quadrantenopia. It's because it sits below. Now, if you had a tumor that was sitting above and pushes down, you'd lose inferior vision. Does that make sense? So that's why I can actually put it. Bitemporal hemianopia is a very textbook question, but it can actually be superior quadrantenopia, and it's because of that compression from below to the. Excellent. So condition, we talked about one functioning condition, that was our prolactinomas. Now we're going to talk about acromegaly. So they're both functioning, they both secrete. The first one secretes prolactin, and acromegaly was secreting something called growth hormone. So acromegaly is usually a rare clinical condition resulting in excess secretion of growth hormone, which stimulates production of insulin-like growth factor. Majority of the time, acromegaly is usually caused by a pituitary adenoma. This has come up on the exam a few times. I've always seen acromegaly here every now and then these are the things you'll see most commonly. You know, coarse facial appearance and have that spade-like hands. That's the word they use in the exam. That's the clincher, spade-like hands. They'll have increased shoe size. These guys will be like a size 15, 16. They'll have very large tongue. Progantism, what that basically means is this jaw. You can kind of see how this jaw sits up. It's large and it sits more anteriorly. At the same time, this is also important, interdental spacing. So what happens is the growth hormone causes bones to grow so fast that the teeth can't catch up. So the jaw gets very, very large, and then the teeth kind of have bigger spaces in between. So they end up having interdental spaces. You can have excessive sweating and oily skin. Why? Because of the hypertrophy in the sweat glands. Lead to the pituitary tumor, you have the hypopituitarism, headaches, bitemporal hemianopia. Once again, you're getting those classic mass effects. There'll be raised prolactin in about 1/3 of cases. Once again, if you have hypopituitarism, you're going to have decreased dopamine, you're going to have less inhibition of that prolactin. 6% of these patients have been associated with MEN1 conditions. What are MEN1 conditions? We'll cover them today. Complications, this is the part I want you guys to remember, come with hypertension, diabetes, very, very, very important. Cardiomyopathy, a lot of these patients will go into cardiac heart failure. They'll go into HFrEF or HFpEF. And they have colorectal cancer. Now, the reason is, so growth hormone typically affects three things. It affects the osteoblasts, so you have increased bone growth. It'll affect your liver, so you'll have more glucose being released. And at the same time, it'll also affect your muscles, so you'll get larger muscle mass. That's why a lot of people who are bodybuilders will end up injecting themselves with growth hormone to build that mass. Now, you can imagine that if you're going into the liver and you're causing all of this sugar to be released, there is a high chance that you become insulin insensitive. So you're going to end up developing diabetes. Why? Because of that chronically high level of glucose. So the acromegaly is very, very related to diabetes. Why? Because once again, GH will go act on the liver, will cause your liver to secrete more sugar, will cause that higher release of sugar. It also will increase that insulin-like growth factor, and then that will end up causing things like cellular metabolism. It stops apoptosis, so it stops cell death, and it actually helps cells differentiate. Now, if it stops cell death, what will happen? Well, these patients normally will have polyps, and now there's no programmed cell death, so what will happen is they have an increased chance of colorectal cancer. That's an effect of the insulin-like growth factor. Remember, this is directly associated with diabetes. Now, this is the classic presentation of when you see on the exam, these enlarged shoes. In the exam, they'll say as a kid, he kept changing his shoe size. So he was a size 7, then 9, then 12, and it keeps getting larger. Another thing is the cardiomyopathy. These guys will have an increased heart size. Have that progantism, that jaw. You have mass effect. You have that facial disfigurement. You'll have that spacing of the teeth. And most importantly, remember that spade-like hand. That's the same words they use in the exam. How do we diagnose it? So growth hormone, the thing about growth hormone, it secretes variably throughout the day. So that's why we don't measure growth hormone, because it's not very accurate. If you take it at different parts of the day, you'll get different results. So the thing we typically, Yes.
Yeah, sorry, could you take the reason they get colorectal CA again? You said something
So,
about cell death.
Yeah, so insulin-like growth factor, one of the things it does is it stops programmed cell death, so apoptosis, right? Why is apoptosis so important? Because that is actually what stops us from getting cancer. The old cells die, right? And so new cells can come forth. In this case, the old cells aren't dying. And it also helps with differentiation of the cells and cell growth. So at that same time, what's happening is you're inhibiting cell death. So those old cells are sticking around. They make more, obviously, we know that cells that stay around for longer have an increased chance of mistakes in DNA replication. And once there's mistakes in DNA replication, that's how you get your cancer. So these people are correlated with corollary cancer. But for the exam, these are the four most, there's lots of complications. These are the four most important ones you need to remember.
Okay, but what about the hypertension and the diabetes? Is there any like pathophysiology behind that, or we should just know that
Once again, in diabetes, so hypertension is because of the cardiomegaly, you get a larger heart. So that's probably why you get the hypertension. For the diabetes, once again, IGF goes and acts on the liver, which causes more glucose to be released, right? Because this also causes muscle mass to be like grow bigger, right? Bodybuilders use the same drug. So it causes more sugar to be released. Now your body is in a constant state of elevated sugar levels, right? That sounds very much like diabetes, doesn't it?
Yes.
So that's actually what it causes. So the initial test that we do is an IGFI, so the IGF-1, sorry. So this is the screening test we do. Before we used to use OGTT, we no longer use it as a screening test. And OGTT is used to confirm the condition. So something that's very, very interesting is when you do an OGTT, what will end up happening in a normal patient, your growth hormone will be suppressed. When you have elevated levels of elevated levels of sugar, your growth hormone will be suppressed in a state of hyperglycemia. However, in a patient who's got acromegaly, there will be no suppression. They will continuously secrete growth hormone. So that's how we can kind of see the difference. So screening test, IGF-1, confirmatory test, OGTT. And then, of course, you can use an MRI just to see the size of the tumor, the mass of the tumor. It's the best source of imaging. But please keep that in mind. IGF-1 now has overtaken OGTT with serial GH measurements as the first line. OGTT is now used and that is recommended to confirm the diagnosis. So IGF-1 and then confirm it with an OGTT. This is by the Royal College of Endocrinology. This is their recommendation. Treatments. What is the first line treatment? Is transsphenoidal surgery in a majority of patients. So quite interestingly, it's the opposite to the last one. In prolactinomas, we typically go with cabergoline. In acromegaly, we typically end up going with transsphenoidal surgery first. If the pituitary tumor is inoperable or surgery is unsuccessful, then we can go through medication. I mentioned this drug very briefly, not actually quite thoroughly, in the upper GI bleeds when we did GI together. So one of the things we can give is somatostatin analogs. These directly inhibit growth hormone secretion and cause it to shrink. The drug we give is octreotide, right? That's the one I talked about. We give it in variceal bleeds. And I said we don't give it long-term because it can cause something like cholestasis, cause more stones to occur. That's why in these patients, this is where the study came from. They noticed in people who had acromegaly, who were taking octreotide for extended periods of time, were having issues with cholestasis. Their bile was not able to move because of that same somatostatin analog. It's effective in about 50 to 70% of patients. The other drug we can use is pegvisomant. It's a growth hormone receptor antagonist. It blocks growth hormones, but it does not reduce the secretion. It's given once a day. It's very effective. Decreases IGF-1 levels by 90% normal. Doesn't reduce the tumor volume. Therefore, surgery will still be needed to get rid of the mass effect. It's that compression symptom. You'll still need surgery for that. Excellent. I've got a question here. We'll go Dr. Ruth, please.
A 45-year-old gentleman presents to the endocrinology department with coarsening of facial features and increased skin thickness. An oral glucose tolerance test finds a lack of suppression of growth hormone. A subsequent MRI of the pituitary detects an enclosed pituitary microadenoma of 9 millimeters diameter. Which of the following management plans is first line for treating this patient's pituitary adenoma? So from the stem, worsening facial features, increased skin thickness, we're thinking acromegaly from pituitary adenoma. Yes, so first line we said transsphenoidal surgery.
Yep, absolutely. Once again, this is different to prolactinomas. Please don't, the prolactinomas is the opposite. We give drugs first and then surgery. This one we surgery and then we drugs.
Yeah, and then for the OGTT, I still don't really understand like how it's useful here.
So the reason why it's useful is in OGTT. So in the normal person, so me being somewhat normal, if I was to have elevated levels of sugar, my growth hormone would be inhibited. So what happens is in these kind of people, we give OGTT, the oral glucose tolerance test. Remember, we give 75 milligrams of glucose to the patient. They eat that, and then we see how they react to it, right? In a normal person, when you give that glucose, it'll cause GH to drop. So us in normal people. However, in a person with acromegaly, they have a tumor that is constantly secreting GH. So there's no inhibition. So in those kind of people, we'll see that there's no difference to the GH. GH will still be elevated.
Okay.
So that's how we do it. But once again, very, very important. IGF-1 is the first test. OGTT is used to confirm it. Let me find a photo of it in the back. Oh, no. So normally when it comes to the surgery, they stick a long probe up your nose towards the back through the sphenoid bone, and they remove it. What are we doing for time? All right. Let's take a quick 5-10 minute break, and we'll come back to it, everyone. I think let us continue where we left off. Go back, probably wait another minute.
As we wait, Dr. Umar, the second drug, pegvisomant, yeah,
Pegvisomant, yeah.
it was a GH receptor antagonist. Okay, okay.
All right. We'll start. Begin it. Yep. Okay, so we've covered functioning tumors. Now we're going to move on to hypopituitarism. Once again, a classic pituitary diagram that we've had all the time. The reason it's important now is, once again, like I said, depending on where that compression is, depending on where the damage is, those are the hormones that are going to be missing. So what are the causes of hyperpituitarism? It could be a few. We've got compression of the pituitary gland by non-secreting microadenomas. That's the most common cause. We have pituitary apoplexy. This happens in an acute pituitary hemorrhage or infarct. We have something called Sheehan syndrome. Once again, we talked about this briefly in GI, I believe, where someone who's gone through postpartum hemorrhage, they've lost so much blood that there isn't enough sufficient blood flow to the pituitary gland, which causes an ischemia and then damage. We've got hypothalamic tumors, so craniopharyngiomas. We've got trauma and iatrogenic irradiation. So either we've given them sort of radiotherapy, which has caused this damage. Now, what are going to be the symptoms of hyperpituitarism? It could be anything. It could be very, very broad. The symptoms will depend on what hormones we're losing function, right? So signs and symptoms of depends on what hormones are deficient. Growth hormones and gonadotropins, so FSH, LH, deficient earlier than other hormones. But if we have an LH, FSH deficiency, we're going to have those amenorrhea, infertility for women, erectile dysfunction for men. If you have growth hormone deficiency, these typically don't cause a lot of symptoms in adults. But when it does, it would cause things like central obesity, decreased strength. Once again, we said that growth hormone is responsible for that same thing, that muscle density, right? That increased muscle mass. So if you have a lack of that, you'll have that decreased strength. If your TSH is deficient, you're going to have that same hypothyroid disease. You're going to have fatigue, cold tolerance, weight gain, the symptoms of a hypothyroidism. If you have ACTH deficiency, you're going to have that fatigue, the weight loss, the hypotension, the hyponatremia, all of those same things that we studied before. And at the same time, pituitary tumors can sometimes cause specific hormones to be secreted with decreased secretion of other hormones. Example, acromegaly, where growth hormone could be increased, but the rest of the hormones could be deficient. So how do we investigate any sort of hypopituitarism? We do something called triple stimulation test. And at the same time, we do an MRI. So we have imaging and we have some sort of microbiology, microserology or something. So what exactly is this triple stimulation test? Just like the name suggests, we usually give 3 hormones that are synthetic and we give them to the patient and we see how they respond to it. So the 3 drugs that we typically give are insulin, and we see how the growth hormone and the cortisol responds. We give GnRH, and we see how the LH and the FSH responds. And we give TRH, and we see how TSH and prolactin responds. Now, what would be the treatment? It all depends which hormones are being deficient, which of them are low. So if you have decreased levels of, let's say, thyroid stimulating hormone, we know that we're going to have hypothyroidism. So at that point, we can start treating that condition. If we have things where we have LH, FSH is deficient, we can start secreting, giving them more GnRH to help that. Basically, supplement whatever is missing. You could do that, surgery or radiotherapy. Now, pituitary apoplexy, it's mentioned. I don't think you need to know it very, very in depth, but it's what we consider a genuine endocrine emergency. It only happens to the patients with these adenomas. It usually presents with sudden onset of headache, hypopituitarism, you may or may not have visual loss, eye movement disorders, and altered levels of consciousness. The diagnosis is usually made on CT. And the reason is it's typically when we get these kind of symptoms, we get worried of subarachnoid hemorrhage. And then we end up identifying that there is no subarachnoid hemorrhage and there is some sort of apoplexy going on. These patients require urgent glucocorticoid replacement and should be managed by endocrine and neurosurgery, with surgery indicated if the visual changes do not improve with conservative management. Now, SIADH, all of us have probably learned about this in med school, have seen it in practice perhaps, if we're lucky enough. But SIADH is what we call symptoms of inappropriate ADH secretion. The syndrome of inappropriate ADH secretion is categorized by hyponatremia secondary to the dilutionary effect of excess water retention. Patients with SIADH are typically euvolemic. They do not show signs of overt volume depletion overload. In very, very, very simple terms, SIADH means you have too much ADH being secreted. What is ADH? The way I think about it is it's called, well, firstly, it's called antidiuretic hormone. The way I think about it, I call it anti-peeing hormone, right? This is the kind of hormone that will cause you not to pee and retain more fluid in, right? So how does it typically work? SIADH involves an excess release of ADH. We also call that a vasopressin. What that does is it leads to water retention and volume expansion with dilutional hyponatremia. So essentially what ends up happening is this ADH will go, it'll be secreted by the posterior pituitary, not the anterior. Remember, there's only two hormones secreted from the posterior, that's your oxytocin and your ADH. It'll be secreted from the posterior pituitary, it'll go and act on the distal convoluted tubules and the collecting ducts inside the nephrons, which are found inside the kidney. What the more specific, it'll act on something called aquaporin receptors or aquaporin ports. What that'll do is it causes more water to be retained. So we have a decreased secretion of fluid, of water, and we retain most of it. So yeah, once again, like the name says, it's an inappropriate and continuous release of ADH, and it's not inhibited by normal physiological mechanisms, such as adequate or excess body fluid level. So normally you have these osmoreceptors inside your brain and the pituitary gland just above it, where you'll actually measure the osmolality in your blood. And depending on the osmolality, your body will secrete ADH or stop secreting it. In this case, unfortunately, these patients continuously secrete ADH, and what happens is they end up retaining a lot more fluid. As a result, the kidneys reabsorb more water, leading to decreased urine output and expansion of extracellular fluid volume. Importantly, this increases the body fluid volume, but it does not you would expect all of this fluid to be left in the body, but then you're thinking, okay, I'm going to have this pulmonary edema, I'm going to have peripheral edema in the limbs, but you don't get any of those symptoms. Why? Because all of that fluid is distributed throughout the body uniformly. So you won't have those signs of peripheral or pedal edema. You're not going to have that hypertension. You're not going to have you're not going to have any of those like basal respiratory crackles or fluid overload symptoms. Once again, the fluid is distributed uniformly across the whole body. However, as a result, what ends up happening now is, unfortunately, you have so much water and not enough solute, you become diluted, and you get into the state of hyponatremia, right? So a lot of the symptoms that are associated with SIADH are actually those symptoms of hyponatremia. Now, what are those symptoms? This is classic. I pinched this from osmosis, but it says it very, very nicely. Salt loss, stupor, coma, anorexia, lethargy, tendon reflexes will be decreased, limp muscles, orthostatic hypotension, seizures, stomach cramping. Now, what are the causes of SIADH? If you look at the top, you can see that when it comes to malignancy, you have small cell lung cancer as one of them. You could have pancreatic or prostate cancer. Neurologically, you could have a stroke, subarachnoid hemorrhage, subdural hemorrhage, meningitis, encephalitis, abscesses. Could be due to an infection such as TB or pneumonia. Could be because of some drugs we're taking, SSRIs, tricyclics, sulfonylureas, carbamazepine, vincristine, cyclophosphamide. Other causes are positive and expiratory pressure or porphyrias. How do we investigate it? So we have this criteria. It's called the Barrett-Schwartz criteria. This is how we diagnose SIADH. A few things you guys need to see here is decreased serum osmolality. What does that mean? Is we're retaining more fluid in the serum, so we have dilution. So there's a decreased osmolality. What will happen is since we're not secreting enough water, our urine becomes more concentrated. So you have increased urine osmolality. You'll have euvolemia. You'll have increased urine sodium. No other causes for hyponatremia should be there. So you shouldn't have any you're not using any diuretics. There's no suspicion of hypothyroidism, cortisol deficiency, proteinemia, hyperlipidemia, hyperglycemia. So there's no other causes. Most importantly, you guys need to remember is that serum osmolality goes down, urine osmolality goes up. Now, my question to you guys is, okay, why is urine sodium high? One, of course, we know that we're retaining more fluid, but also why is the sodium number high?
Don't know how it exactly happens, the mechanism, but what you have when you have elevated levels of ADH decreases the levels of aldosterone, leading to increased urine sodium loss. Why that happens exactly, I'm not sure. I don't know.
That is good enough for me. Absolutely, Dr. Fry. So, absolutely, increased levels of aldosterone, ADH, actually cause decreased level of aldosterone. It's got to do the same thing with those osmoreceptors in the top. So it's got to do with vascular expansion and the stimulation of the RAS system. So when ADH is high, aldosterone actually comes down. That's usually the pathophysiology about it. And when aldosterone is down, what happens is we have that decreased sodium reuptake. So you end up losing more sodium into the urine at the same time. That's why you have increased urine sodium of more than 20 millimoles. And at the same time, you have all of this fluid left inside the body. So you get this almost double hyponatremia. One, because you're losing it, and two, because you're diluting it. How do we manage SIADH? So the first consideration in the management of SIADH is to treat whatever's causing it. Like I said, we had all those other conditions. It could be the hypothyroidism, cortisol deficiency, infection, diuretics, hyperglycemia, pseudo-hypernatremia, all of these things. So the first thing is if we can identify a cause, treat the cause. After that, what do? Is we try to confirm it. If we've ruled out all of the causes, we try to confirm it. How do we do that? We can use the same criteria, the Barrett-Schwartz criteria. You can see over here, they're only looking at three things: decreased serum osmolality, increased urine osmolality, and increased urine sodium. After that, we kind of see, is this symptomatic, is this asymptomatic? If the asymptomatic, we just recommend a fluid restriction. If the symptomatic, we look at the duration, how long have the symptoms been going on. If it's been less than 48 hours and it becomes symptomatic, we get really, really worried about brain injury. So at that point, we can do hypertonic saline bolus, which is 3%. But this is very, very scary. I'll explain why. This is actually considered a specialist drug. You know, as an RMO, you will not be giving this. You'll have to have some sort of, one of the bosses will be there to administer it. At the same time, if the symptoms have been going on for more than 48 hours, we can do that. Or if they're minor symptoms, we once again do fluid restriction. Now, the reason I was talking about the hypertonic saline solution is if you administer it too fast, too quickly, you can end up having something called cerebral demyelination, which is an irreversible neurological condition. You'll get that locked-in syndrome, and you can't fix it. And that's actually really crazy that only water with some salts in it can actually cause that. It's irreversible. So that's why we don't try to, like, even when we do give this, we try to be very, very cautious. Like as an RMO or a PHO, you'd be really, really worried. You'll have to get one of the bosses to help you do that. So yeah, it's been, if you end up giving it too fast, it's associated with cerebral demyelination, which is irreversible and most commonly fatal. It may not be evident for several days until after the treatment. The patient recovering from hypernatremia may deteriorate unexpectedly, depending on the area of the brain affected. A variety of neurological, psychiatric symptoms may develop. But this is the generalized flow chart that we have for treating SIADH. I think this is also from RACGP, or it's Australian Journal of Physicians. Excellent. So now we talked about a condition when we have too much ADH, which is like SIADH. Now we'll talk about the opposite side. What happens when you don't have enough ADH? Your ADH is very low. This condition we call diabetes insipidus, and it comes in two forms typically. There's a third form, but for the sake of our lecture here, we'll talk about these two. So the first form is cranial diabetes insipidus, or what this is the other name. You do need to know it. This has actually come up in the past papers. They don't say diabetes insipidus. They say arginine vasopressin deficiency. Now, if you remember, vasopressin is just the other fancy name for ADH. So what happens here is it's of cranial origin. So what happens, the brain is not releasing enough ADH. And then you get those symptoms of polyuria, polydipsia. You can't concentrate your urine. The other cause is nephrogenic diabetes insipidus. Those are the two forms. The next one is renal in origin. This one is called arginine vasopressin resistance. So what happens here is you do secrete the right levels of ADH. However, your body does not end up responding to it. So your kidneys don't respond to the ADH. It's insensitive. This kind of reminds you of that very similar condition we talked about in our second or first lecture, where they had patients who didn't respond to PTH, the parathyroid stimulating hormone. Although they do secrete the right levels of it, their body doesn't respond to it. I can't remember the name. Does anyone remember? Can anyone recap? It was one of those syndromic things.
Pseudo-hypoparathyroidism.
Yeah, super hypoparathyroidism.
Yes.
Absolutely, yes. You're insensitive. Yeah, it's the same. Yeah. It's the same thing over here. This is nephrogenic. So you secrete the right levels of ADH, however, you do not respond to it. And the third one has got to do with pregnancy, and I think it's because of the placenta secreting its own inhibitory. It secretes a hormone which inhibits ADH secretion, and then you end up having diabetes insipidus during pregnancy, which is quite odd. And then the treatment ends up being just deliver the child, and they end up recovering within 2 months, within delivery or 2 months after. So interestingly enough, I don't know if you guys find this interesting, but diabetes itself ends up just meaning urine, and insipidus actually means tasteless. So diabetes mellitus, on the other hand, means urine, but sweet. So sweet urine. This one is tasteless urine. Why? Because once again, there's no sugar in the urine here. The problem is not because of sugar. The problem is because of ADH. It's not because of diabetes, even though the name is very misleading. Yes, someone actually did used to drink the urine to tell the difference. So what are the causes of diabetes insipidus? If you're looking at cranial causes, it could be idiopathic, it could be post-head injury, pituitary surgery, craniopharyngiomas, infiltrative disease like histiocytosis X, sarcoidosis, or something called Didmod. This is a whole syndromic thing. So it's got things like cranial diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. So this is also known as Wolfram syndrome, but it's a combination of it's a constellation of all these diseases. And the other one is hemochromatosis, a beloved friend. Now, if it's nephrogenic, just like the other pseudo-hypoparathyroidism, the most common form is because of genetics. And then what happens here has got to do with the ADH receptor. It becomes insensitive and it doesn't work. Electrolytes could be you'll have hypercalcemia, hypokalemia. It could be due to lithium. What studies have actually shown is that lithium actually desensitizes the kidney's ability to respond to ADH. It could be to another drug such as dimbocyclosine, or it could be of tubulointerstitial diseases that are obstructive, or sickle cell, or pyelonephritis. Another one is actually polycystic kidney disease, is another thing, another etiology of nephrogenic diabetes insipidus. Now, if there's decreased levels of ADH, what would you expect? Right now, we're not retaining any fluid. We're just going to continuously lose all of that fluid, right? So you're going to have that polyuria, excessive urination, polydipsia. You're losing so much fluid, you get super thirsty, so you start drinking excessively. You can get nocturia. You want to go to the toilet when you're sleeping. You have loss of weight. The weight is mostly fluid that you're losing. You'll have past history or a family history of diabetes insipidus. You could have some sort of head injury, constipation, neurological symptoms, early morning headaches, vomiting, altered sensation, weakness. And also, it could be due to some sort of medication, most commonly diuretics. And the one we use a lot that we're quite in trouble about is actually furosemide. Oftentimes, when we give furosemide, we see a lot of that electrolyte just start going down, especially the sodium drops. How do we diagnose it? We can use urgent blood glucose levels to exclude diabetes mellitus. Once again, diabetes insipidus it's completely misleading. It has nothing to do with diabetes. So if you do a blood sugar level on these people, it'll look completely normal. At the same time, you do UEC, CMPs, urine dipstick. You can check for the specific gravity and the glucose levels. Paired early morning urine and serum osmolality in diabetes insipidus. Serum osmolality is usually high with inappropriately dilute urine. Consider renal ultrasound, particularly in nephrogenic diabetes insipidus. You might see a change in anatomy. And you can do something called a water deprivation test. This will help distinguish between central diabetes and nephrogenic diabetes insipidus, as well as something called primary polydipsia. Does anyone know what primary polydipsia is?
It's just psychogenic.
Yeah, it's exactly psychogenic polydipsia. It's what I do all the time. I just have this water bottle I keep drinking over and over and over again, and I've created some sort of pseudo hyponatremia. There's no pathology. It's just because I drink too much water. If it's concerned for central diabetes insipidus, what we want to do is a brain MRI, and we do an MRI of the brain and the pituitary, and we can screen for other anterior hormones, pituitary hormones at the same time. So
Yeah,
the water yep.
What's CMP and UEC?
So UEC is like urea electrolyte. So
Creatinine.
UEC or UEG, that's your regular screening. CMP is a complete metabolic panel, so that has all of your other electrolytes on it stuff. Depends where you are. Even where I am, we just call it UEG, so that's urea electrolytes and glucose. But it's just basically one of your routine blood tests. It just shows you all your abnormalities. Now, your water deprivation test. The way this ends up working is I've also added a link at the end of the lecture. I would recommend you guys give it a quick watch. But the water deprivation test, what it is essentially, at the beginning, we tell them to not drink any fluid for 8 hours. And then what we do is we measure the urine osmolality, and then we give them desmopressin. Desmopressin is just artificial ADH, and we see how they react. And then after 8 hours, we measure the urine osmolality. So a person with cranial diabetes insipidus, so this is a person that does not secrete ADH, but they will respond to it, right? So you'll see that the osmolality before will be quite low, but as soon as you give them ADH, they can concentrate it after, right? So that's why it'll become high. A person with nephrogenic diabetes insipidus will not respond to ADH, whether he makes it, whether he gets exogenously. So you'll see that it'll be low in the beginning, and then after giving ADH after 8 hours, it'll also be low. A person with primary polydipsia, at this point, just at the beginning, you'll measure, and you'll see that the osmolality is high. So there's never been an issue. So in this case, there's no diabetes insipidus, and we don't have to actually do the whole entire test. We don't even need to give them the desmopressin. Now, when it comes to the management of this condition, we treat them depending on the cause. Nephrogenic diabetes insipidus is notoriously extremely difficult to treat. It's very, very, very difficult. A lot of these people end up dying, and it's once again very, very, very rare. I think it's in the dozens. It's probably around maybe the hundreds. It's not very common at all. Cranial diabetes insipidus, once again. So these are people that do not secrete ADH. So what do? We do a hydration assessment. We can give them IV fluids, correct electrolyte imbalances. And what do? We give them artificial ADH. So we give them desmopressin. and then they use desmopressin continuously. It's a lot more simpler to treat, right? In nephrogenic diabetes insipidus, the problem is they secrete ADH, but they do not react to ADH. So in these people, what do? We do hydration, low sodium, low protein diet to reduce urine solute load and urine output. And then we can start thinking about thiazides. But the problem is, just like I said before, if you give thiazides, everything starts to drop. So then we have to continuously try to correct that. We have to correct the calcium, potassium, magnesium imbalances at the same time. So that's why nephrogenic diabetes insipidus is a lot harder to treat. In cranial diabetes insipidus, just vasopressin and you should be fine. Excellent. This question will go to Dr. Nitin, please.
All right, so a 45-year-old male is investigated for polyuria. A water deprivation test is done to ascertain the cause. Water deprivation started at 8 p.m. Plasma osmolality after 8 hours is 305. Urine osmolality after 8 hours is 190. Urine osmolality after 4 hours after desmopressin is 575. Based on the presumed diagnosis, what feature is this patient most likely to have in the past medical history? And lithium use is that yeah, so I either surgery or lithium use.
Doctor, your mic is off.
Yeah, it's me.
Doctor, mic is off. Microphone is off.
Thank you. Sorry, I thought I turned it back on. Yeah, so it's definitely you're along the right lines. Is this transphenyl? Is it lithium? But you have to look at that little blood test. That's what's kind of will show you. So your urine osmolality after 8 hours is 190. Urine, and after 4 hours, it's kind of increased, right? So you've given some ADH, and then the urine osmolality has increased. Is that cranial? Is it diabetes? Is it nephrogenic?
It's cranial.
Cranial.
Yeah, it's cranial, right? Because once again, this person is reacting to the desmopressin, right? So you can see that it's concentrated now. Prior to this, if example, it was 190 before, and then it was 190 after, it's low in both cases. So what's happening? The body is not responding to ADH. But over here, it is responding. You're able to now concentrate urine. Most commonly, it's a cranial cause. Most common reason of cranial cause, or one of the causes of cranial cause, is some sort of cranial surgery. Excellent. Yeah. So yeah, if it was concurrent lithium use and we thought it was nephrogenic, so in example, if this was 190 here and then after giving desmopressin, it was still 190, we would say, okay, he's not responding to desmopressin, therefore it must be a kidney problem. At that point, lithium would be our question, or it could be polycystic kidney disease. Excellent. We're going to start looking at some tumors right now. I'm pretty sure a lot of you guys would have covered most of these in oncology, but I'll try to cover what I can here. Now you've heard about these MEN1 tumors, MEN2, MEN2B. These are, what do they stand for? It's a multiple endocrine neoplasm. These are inherited and they're autosomal dominant. They come in 3 forms. You have MEN type A, MEN type 1. So the way I look at it, the way I like to remember it, all of them come in pairs of 3. They all come in 3s. So type 1 will have 3, type 2 will have 3, type 2B will have 3 plus 1. But type 1 will have 3 Ps, type 2A, 2 Ps, type 2B, 1 P. So the 3 Ps in type 1 are parathyroid tumors, 95% of the time. Hyperparathyroidism due to hyperparathyroidism. The second P, pituitary. The third P, pancreas. So this will have things like insulomas, gastromas, these kind of diseases. It could have also adrenal and thyroid. But those are your 3 Ps, pancreas, pituitary, parathyroid. They're associated with the MEN1 gene. And the most common presentation is the hypercalcemia. Why? Because 95% of them will have some form of hyperparathyroidism. And we talked about hyperparathyroidism is linked to hypercalcemia. That's why it's the most common presentation. Now, men 2A, you'll have two Ps. You'll have parathyroid and something called pheochromocytoma. At the same time, you will also have medullary thyroid cancers, right? So that's our three. These are associated with the RET oncogene. Now, men 2B will have 1P, pheochromocytoma. But the other two that we want to think of is medullary thyroid cancer, marphoid body habitus, it's okay, and neuromas. This is also associated with the RET oncogene. So, yeah, once again, this is just a really, really nice chart over here. You guys can kind of see it. It kind of shows how that between men 1 and 2A, you have primary hyperparathyroidism that's kind of shared between the two. Between type 2A and 2B, everything is shared essentially, except in 2B, you can also get neuromas and marphoid body habitus. Now, we talked about something in that chart. It was called a pheochromocytoma. Once again, you can see that in that type 2A over here and the type 2B, right? What exactly is a pheochromocytoma? It's a rare catecholamine secreting hormone. About 10% are familial and may be associated with men 2. So it could be 2A or 2B. It could be associated with neurofibromatosis and something called von Hippel-Lindau syndrome. So anyone know what von Hippel-Lindau is? So I'm sure you guys would have seen this and done this in your AMC studies. Essentially, it's kind of like a rare genetic state where you have a high tendency of having gastric tumors. They have multiple hemangiomas across the whole GI tract, but they're very, very prone to getting sort of these cancers. Now, when it comes to pheochromocytoma, we have something called the rule of 10. 10% are bilateral, 10% are malignant, extra-adrenal in about 10% of the cases. The most common place that you find it outside of the adrenal gland. So the most common place is the adrenal gland, but then 10% of the time you'll find it in something called the organ of Zuckerkand right over here. So we have the aorta, there's a bifurcation. This is right next to it. So 10% of the time you'll find it here. 10% of them are familial and may be associated with men 2, neurofibromatosis, and von Hippel-Lindau syndrome. And 10% are not associated with hypertension. So classically, you'll always remember whenever you have these catecholamines, they have a blood pressure like 190, 180, it's these crazy, crazy high levels. But 10% of the time, they may not have any hypertension. That is the rule of 10. What are the symptoms? So if 10% of the time they don't have hypertension, 90% of the time they will. So around 90% of these cases will have hypertension, they'll have headaches, palpitations, sweating, anxiety. Typically, people use this mnemonic called the 5 Ps. So pain, pressure, perspiration, palpation, and pallor. How do we diagnose it? We do something called a plasma-free metanephrine or normetanephrine test, or we do 24-hour urine total catecholamine. But you can kind of see most of the times you'll see these on the adrenal gland. But the other 10% of the time you don't see them, you see them in this place, the organ of Zuckerkand. Now, how do we treat it? You can kind of see this. This is a huge, huge, huge tumor right up here. And even over here, you can kind of see this huge kind of tumor at the top. So pheochromocytomas should be surgically resected. There's currently no consensus whether we should do surgery. There's currently no consensus, but typically we do end up getting surgery in people of a younger age, less than the age of 40. Why? Because we think about the long-term effects of having increased catecholamine. It's a decreased quality of life. So in these patients, younger patients, they're also good candidates for surgery. Surgery would be a better approach. Whereas when you can't do surgery, we can do something, we give them typically alpha blockers and beta blockers. But you need to know this for the exam. There have been past papers that talk about this. You give alpha blockers first, and then you give beta blockers after. So the reason behind medical management with alpha blockers and beta blockers is it's typically used to control the blood pressure to prevent intraoperative hypertensive crisis. So the reason you give alpha block blockade with phenoxybenzamine starts about 7 to 10 days before the operation to allow for expansion of the blood volume. Only once this is achieved, then can you give beta blockers. If beta blockers are started too soon, you have that unopposed alpha stimulation. This can precipitate a hypertensive crisis. So typically, when you're going in for surgery, you want to give those alphas and then we give those betas. Now we've got thyroid cancers. So thyroid cancers, features of hyperthyroidism or hypothyroidism, it could be both. These are not commonly seen in patients with thyroid malignancy as they rarely secrete thyroid hormone. Now, when it comes to thyroid tumors, 70% of the time you have papillary tumors. The prognosis with thyroid tumors are usually very, very good. They're about 95% 5-year life expectancy. It's very, very good. 70% of these tumors are papillary tumors, 20% are follicular, 5% are medullary thyroid tumors. These are associated with our MEN2A and MEN2B diseases. So what happens is basically this is a cancer of the parafollicular cells. They secrete something called calcitonin, and it's part of those MEN2 conditions. Calcitonin is what we use to measure the response to therapy for these patients. So in these patients with medullary thyroid cancer, calcitonin will be extremely elevated, and that's how we monitor it. One of the other conditions is something called anaplastic thyroid cancer. Absolutely terrible. About 1% of these patients have it, but it's a terrible, terrible prognosis to have. I think the mortality rate sits around 90 to 95% in 1 year. So it's almost as bad as pancreatic cancer. It's very bad. So these patients are typically not responsive to treatment, and it can cause pressure symptoms. The other one we want to think of is lymphoma. When it comes to thyroid cancers, these are associated with a Hashimoto's thyroiditis. We talked about this in our first lecture. So management of these papillary or follicular cancers, we can do a total thyroidectomy. If this is the part you need to know for your exam. Total thyroidectomy followed by a radioiodide of 131 to kill residual cells, and yearly thyroglobulin levels to detect early recurrent disease. Now, this is a really, really nice chart that you can kind of look at to see how we're going to end up treating suspected or confirmed nodules. We look at TSH. If TSH is low, we can do that radioiodine imaging, 99, and in that case, we can refer. If TSH is high, we look next step, we do an ultrasound, and we can do a FNAC or fine needle aspiration cytology, and then we kind of see what we do next. Now, this is another really, really, really good chart that kind of explains the surgical, at what point do we do what kind of surgery. So at what point do we consider a lobectomy? This is usually a unifocal thyroid cancer that's less than 1 centimeters, and it comes within this grading. When do we do a total thyroidectomy or lobectomy? It's between 1 and 4 centimeters, and once again, they have these features. If it's more than 4, straight away we do a total thyroidectomy. And if there's, once again, if there's evidence of lymph node metastasis, then we do thyroidectomy plus lymph node dissection. For the sake of the exam, just remember that if it's more than 4, we do total thyroidectomy. If it's between 1 and 4, we could do a total. It could be lobectomy. And if it's less than 1, we can just do a lobectomy, just remove one part of the thyroid. This is just some extra information I've put down just for the readings. This is something you guys might be interested about. But what it is basically a really nice table and summary of all those different kind of conditions. Excellent. We're on the, okay, yep. So now we're on the electrolyte imbalances. So one of them we're going to talk about is hypernatremia. So a normal serum sodium sits about 130 to 145. So anything above that we would consider hypernatremia. So hypernatremia is usually, depending on who you ask, it's classified into 3 stages. You have mild hypernatremia, where it's between 146 and 149. Moderate between 150 and 170. And severe more than 170. Causes, there could be many, so decreased fluid intake with normal fluid loss, inability to communicate water needs. So these are patients with cerebrovascular accidents, infants, intubated patients. So these are patients who basically, they can't tell you how thirsty they are, or how they have no access or communication of that they need to drink water. Could be hypertonic fluid loss with water loss in excess, so things like excessive sweating. We have dermal burns, gastrointestinal loss, renal loss, so things like diabetes insipidus. Increased salt load, so hyperaldosteronism, ingestion of salt tablets, and administration of hypertonic saline. So what are the clinical features? Once again, if these are people who have excess amount of salt, we're going to think about things like they're going to have increased thirst, weakness, lethargy, irritability. They have altered mental status. So once again, if your sodium is too high, you'll have altered mental status. If it's too low, you'll also have altered mental status. Ataxia, tremor, focal neurological signs. You can have seizures and comas. When it comes to an ECG, there's usually no ECG changes to cardiac rhythm or conduction, very interestingly. When it comes to management, we will do things like high flow oxygen, fluid replacement, hypovolemic patients who can give no IV normal saline without causing too much of a rapid reduction in sodium. So basically what we're trying to do is we're trying to cause a state of dilution. If too much hypernatremia, we try to give them more fluids and bring that sodium level down. This is a really, really nice algorithm that's available. So serum sodium level is for hyponatremia. When it's less than 130, that's when we consider as hyponatremia. Once again, the clinical features depends on how low that sodium falls. So if it's less than 125, usually they're asymptomatic. If there's more than 125, it's asymptomatic. Between 120 to 125, you have things like lethargy, weakness, ataxia, and vomiting. If it's less than 120, then that's when you have all your terrible symptoms like confusion, headache, convulsions, and coma. Management, the rate of correction of hyponatremia should not exceed 8 millimoles per liter in 24 hours, as over rapid correction can cause that same thing I talked about, that demyelinating syndrome. And this is once again a really, really nice kind of algorithm where you can watch and go down and figures out how fast should you be correcting the sodium. Next condition is hyperkalemia. So hyperkalemia is typically when the potassium is 5. Normally it should sit somewhere between 3.5 and 5, or more than 6 milliequivalents in neonates. Hyperkalemia is potentially life-threatening and can result in cardiac arrhythmias and sudden death. Unfortunately, a lot of the time, if the potassium is way too high, you'll end up going into VTAC, and it doesn't get better from there. It can go lead straight to cardiac death or PEA if it's not corrected within time. What are the causes? Either you're not excreting enough. These are the most common causes. So renal disease, acute kidney injury, chronic kidney failure, renal anomalies, adrenal mineralocorticoid deficiency. There's some sort of transcellular shift where you're causing a lot of this potassium out of the cell into the plasma. So acidosis, things like DKA, lactic acidosis. Increased production most often is associated with renal dysfunction. So you're having too much potassium. So what this could be because of an extensive trauma, rhabdomyolysis. What ends up happening is, you probably remember this in med school, a lot of our living cells are described as bags of potassium, right? So people who end up having trauma will end up having those cells rupture, and all that potassium will be secreted in the serum. So crush injuries are very, very dangerous for that. Convulsions, infections, hemolysis, tumor lysis syndrome, and burns. It could be exogenous sources, so either someone just taking too much potassium in, increased ingestion, or massive transfusion. So another reason could also be medications, things like NSAID, trimethoprim, heparin, chemotherapy, potassium diuretics, ACE inhibitors, beta blockers, succinylcholine, digoxin, and mannitol. This is a really, really nice chart. I think it's from the nursing group. Yep, registered nurses. So this is how we typically look at. So between hyperkalemia, so we normally should be 3.5 to 5. What are the causes of hyperkalemia? They use the mnemonical CARED, so cellular movement of potassium from intracellular to extracellular because of burns, tissue damage, or once again, those crush injuries. Adrenal insufficiency. We talk about Addison's disease. Remember, you'll have very, very high levels of potassium. Renal failure, excessive potassium intake, and then drugs. Most commonly, you'll see spironolactone or these potassium-sparing drugs, where, like the name says, it spares potassium, so you'll have high levels of potassium buildup. Symptoms, they use the mnemonic MURDER. They'll have muscle weakness, urine output little or none, respiratory failure, decreased cardiac contractility, early muscle twitches and cramps, and rhythm changes. So on ECG and hyperkalemia, you'll see these tall, stented T waves and a prolonged PR interval. The classical feature of hyperkalemia, once again, is that weakness, ascending paralysis, loss of deep tendon reflexes, and respiratory failure. So we divide it once again, just like all of the other classifications we have in different degrees. Between 5.5 and 6 is mild, 6 to 7 moderate, more than 7 is severe. You'll see these ECG changes. So on hyperkalemia, you'll see that very, very pathognomonic tall stented T waves, right? You'll have a prolonged PR interval with flattening of the P wave. You can see this P wave here. It's not inverted, it's just lower. The amplitude is decreased. You have the QRS that's widened, and eventually you can have absent P waves or sinusoidal waves. So that's very, very cool. It's on our little graph over here. You can kind of see a normal ECG at the top. And then as you go down, as the potassium increases, you can see that ECG looking more and more funky. So you see that tall stented T waves, the flattening of the P wave, that prolonged PR interval. And then eventually when it gets really, really bad, it turns into the sine wave over here. That's when your potassium is like 7.5. This is what a normal ECG should look like, right? You've got beautiful P waves, QRS, you got your T wave at the end. This is what hyperkalemia looks like. It looks like an absolute mess. These huge, huge, huge T waves. At this point, you can't even see what's happening. It's indistinguishable. This is something that's very, very interesting. So at the top, you can see that hyperkalemia, but usually what we do, and especially anyone that comes into emergency, when you have hyperkalemia, we give IV calcium. What IV calcium does, it kind of stabilizes the cardiac membrane at the same time. And you can kind of see this ECG looks somewhat normal now. Now, how do we treat? This is for the exam. Please get this tattooed. I've seen this multiple times. It's very, very important. So hyperkalemia, if it's more than 5, what we do is we try to stop all of the potassium supplements, stop medication that's causing that potassium to increase, and we exclude any other causes. So now, depending on the level, that's what we do. So if it's between 5.5 and 6, we think about treating it. We could give salbutamol, we could go polystyrene sulfonate, or we can go bicarb. If it's between 6 and 7, we are definitely giving salbutamol. We're going to give insulin and glucose. And we can, at that point, we can think about resonium. If it's more than 7, we go dialysis. And then straight after that, you can see we go calcium IV, salbutamol nebulized, insulin, glucose, bicarb. We're doing everything that we can as soon as it's above 7. But this has come up in the exam multiple years, multiple months. They ask you how to manage hyperkalemia, and this is the way. Typically, they'll ask you this point right here in the middle, where it's between 6 and 7. This are the ones that the exam asks, and then what you do if it's more than 7. Excellent. So we talked about hyperkalemia. Now we're
Excuse me, Dr. Mark.
Yes.
I have a question. If
Sure.
we could go back to hyponatremia, I just was wondering if they use Vaptins in Australia.
Sorry?
And drugs like tolvaptan and stuff. Do they use that in Australia for hyponatremia?
Typically, hyponatremia, no, typically what I've seen that we use here, we just end up giving fluids. We give normal saline and we just slowly uptitrate it from there. That's usually the way that I've seen that it's treated here, normally. Even the algorithms, if you look at it, most of the time you have a choice, either saline or you go hypertonic, but we stay away from hypertonic.
All right, thank you.
A small question about hyperkalemia. What is salbutamol for?
So this part, correct me if I'm wrong, I might have to ask Dr. Farai. But typically, salbutamol, from what I remember, is the way it functions, it ends up causing more of the potassium in the serum to move intracellularly, just like glucose and insulin does. So we do insulin and glucose in the same way that all that potassium moves intracellularly, but takes it away from the serum. I believe, don't quote me on this, salbutamol works in a similar fashion. Don't quote me on it. I'm assuming a lot here. Okay.
It causes intracellular shift of potassium.
Yeah, so it does cause an
yeah,
it is an intracellular shift of potassium. There we go. So hyperkalemia here. So hypokalemia is on the other side of the spectrum. So when we have our potassium level too low, below than 3.5. So once again, we do it based on severity. If it's 3 and 3.4, it's mild. 2.5 to 3, it's moderate. 2 to 2.5, severe, and less than 2, it's critical. In the hospital, normally when we see hypokalemia, we just say it's hypokalemia. Nobody bothers to grade. But I don't know how significant this is, but of course, the more lower it is, the more extreme the symptoms will be. So how does it come to management? If it's low, we just replace it. If potassium, so we consider a replacement when the potassium is less than 3, or if the potassium is less than 3.5, but they have symptoms, ECG changes, or some sort of signs. What are the causes? It could be because of decreased intake. It could be because of increased loss, transcellular shifts, medication, and spirochetes. So it could just be an error in sampling, or it could be an IV fluid near the sampling site. So it's some sort of fake or some sort of inaccurate reading. Now, hypokalemia, the other mnemonic that the nurses use is ditched. So you have drugs or things like loop diuretics, furosemide is the most common one I talk about. Inadequate consumption of potassium, too much water intake, Cushing's syndrome, fluid loss, such heavy fluid loss, so nasogastric tube suction, vomiting, diarrhea, wound drainage. Symptoms, sign of symptoms, you have this thing called the 7 L's. So lethargy, low shallow respiration, lethal cardiac dysrhythmias, lots of urine, leg cramps, limp muscles, low blood pressure. This ECG, you'll kind of see that there's a pushing up this stuff here. This is the picture I like. So this is from Life in the Fast Lane. You can kind of see how this patient pushes this little ST depression here, and you get this huge U wave. So that's hypokalemia, and as hyperkalemia, you pull it up. So in ECG changes, you get broad and flat P wave, flat inverted T waves, prominent U waves, QT prolongation, and prolonged PR interval. Yeah, once again, here you can see that inverted T wave down and that U wave being up. Again, here's another one, that down, and then a big large one after. Hypercalcemia. Hypercalcemia is diagnosed on the basis of elevated serum calcium, something between 2.1 and 2.6 is normal. Hypercalcemia has many, but 80 to 90% of the cases in adults results from primary hyperparathyroidism or malignancy. So we've discussed that in our first lecture, right? Most of the time, if you have hypercalcemia, you're going to have it because of that parathyroid hormone. And what do we say the symptoms were? It's those classic moans, groans, psychiatric overstones, psychiatric overtones. That's your hypercalcemia. So how do we manage it? If it's have hypercalcemia, it's usually 2 things. Give fluids and drain them. So we give furosemide and we give them fluids. It's the same management as we saw early on with hypercalcemia, with a lot of those other conditions that we studied. In hypocalcemia, so this is once again, if your calcium levels are too low, you're going to have those classic signs of tetany. I showed you those videos in the chopstick sign and the Trossier sign. We can kind of see when you put the BP cup, you see that little bicep extension, and the chopstick sign is that cheek tapping on the facial nerve. You see that spasming. Common causes of hypocalcemia could be vitamin D deficiency, which is the most common cause, autoimmune hypoparathyroidism, parathyroid injury from surgery, hypoparathyroidism related to congenital disorders, hypomagnesemia, anterior absorptive drugs, autosomal dominant hypocalcemia, and vitamin D dependent rickets type 1 or type 2. Easy. In any sort of hypo or decreased electrolyte, what we do is we just supplement it. So the story is the same thing here. If we see it's hypocalcemia, what we'll do is we'll just try to supplement it. We can give them intravenous calcium infusion. It's hypokalemia, we give potassium supplements. It's hyponatremia, we just give them saline fluid. And oh yeah, this is another really nice table that shows you the same symptoms between hyperkalemia, hypercalcemia, and hypocalcemia. And you can kind of see the mnemonics from, I think this is also from, there's another, this is a really, really good one. They make similar tables and things from like osmosis, but it's not osmosis, it's something very similar. I forgot the name of it, but it's a very good table. I quite enjoy this one, but you can see hyperkalemia, moans, groans, stones, psychiatric overtones. It's that same here. One thing I want you guys to notice is the QT interval is shorter in hyperkalemia, longer in hypokalemia. The way I kind of think about it is potassium is needed when it comes to nerve impulses. When you have a large amount of potassium, you'll have faster impulses, so the QT will shorten. So it happens more frequently, right? And if you have hypocalcemia, you'll have less calcium, so there'll be slower and longer impulses, so the QT will be stretched out. So when you look at an ECG, you can kind of see a normal ECG looks like this. When hypocalcemia, those impulses take longer to occur, so that QT interval increases. In hypercalcemia, there's more calcium, so that impulse is faster, happens more frequently, so that QT shortens. You can see that same thing over here in these ECGs, especially here, this V1, you can see this big gap. And you can kind of see it shortens here as well. This would be in hyperkalemia, especially if you look at V5, V4, V6, it all leads. So here, a normal ECG looks like this. In hypokalemia, you can see that there's a T wave, the U wave. In hyperkalemia, you see that tall stented T wave. In hypocalcemia, you see that QT prolongation. And then hypercalcemia, you can see that QT shortening. Now, I've got a question here. We'll go Dr. Igor, please.
Okay. John, age 4, has been previously diagnosed with metastatic prostate cancer. He's brought to the emergency department by his family due to confusion, which began approximately 1 day ago. John had previously been complaining of increased drowsiness, nausea, decreased appetite, and aching pains in his legs prior to the onset of confusion. John's medications include MST or Amorph and co-Dantromere. His last set of blood results were taken by his GP 2 months ago and showed a slight hypernatremia. Which of the following electrolyte imbalances is the most likely cause of his current symptoms? A, hypocalcemia, B, hyponatremia, C, hyperkalemia, D, hypercalcemia, E, hypernatremia. So we have symptoms such as drowsiness, increased nausea, decreased appetite, aching pains.
Metastatic prostate cancer.
Well, I would go for hyperkalemia, but I'm not sure.
No, in this case, it'd be hypercalcemia. And a really easy tip is when you think of cancer, remember what did I say last time? Cancer, any sort of prolonged inflammatory disease, you get calcium, you get calcification, right? You're gonna have that calcium deposit occur. Any sort of prolonged disease, any sort of cancer, you're gonna have that. So that's my tip. Even if I didn't read the whole story and get the symptoms, the first thing I'll think of is hyperkalemia. Once again, you can see all those stone, bones, groans, all of those psychiatric classic hypercalcemias. But yeah, once again, if you think about any malignancy or any chronic inflammation, think about hyperkalemia. All right, we're going to try to go through, we've got a few questions, not that many. Let's try to get to these as fast as we can. Dr. Misha, please.
Doc, sorry, quick one. What's MST, out of interest? What's MST? From the previous question.
I have no idea. That could be a brand name. I have no idea.
Oh, okay.
I think these are all some sort of, this is probably some sort of supplement, I assume, or a morphmate. Yeah. I'm not entirely sure.
Thank you.
Okay. So Dr. Misha.
A 26-year-old male presents with headaches. His GP finds his blood pressure to be 190/115. He's urgently referred to hospital where investigations show normal hemoglobin, normal platelets, normal leukocytes, sodium low, maybe low, normal potassium, urea, normal, creatine normal, calcium high, PO4 phosphates, don't remember, PTH, high, so high PTH, high calcium, so it could be primary or tertiary Okay, further investigation reveals raised 24-hour urinary catechol and an abdominal mass over abdominal CT was most likely deadly versus men type 1, autoimmune endocrine syndrome type 1, primary hyperthyroidism. Men type 2, autoimmune endocrine syndrome type 2. So maybe we had primary hyperthyroidism and
look at that CT and look at that blood pressure. What do you, or that CT and that catecholamine and the blood pressure? What do you think that is?
What's the question?
The blood pressure is 190 over 115. You've done a 24-hour urinary catecholamine, which is raised. And you can see
pheochromocytoma.
Yeah, pheochromocytoma. So you've got some sort of pheochromocytoma, some sort of parathyroid thing going on here.
So it must be something like men type 2.
Yeah, definitely. Remember, all of the pheochromocytomas are in 2. Now you have to think. Luckily, the question didn't ask you, is it 2A or 2B? But whenever you see pheochromocytoma, think of type 2 diseases. Excellent. All right, Dr. Igor, please.
A 14-year-old girl sees you in the outpatient department with a variety of troubling symptoms. She has suffered with bullying at school due to facial hair and large stature. She also reports menarche was at 10 years old. You organize some investigations which show sodium 131, potassium 6.1, which is elevated, dexamethasone suppression test 8 a.m., cortisol less than 50, testosterone 2 nanomole, plasma 17 hydroxyprogesterone 2 milligrams per liter, which is elevated. What is the most likely diagnosis? Say Turner syndrome, polycystic ovary syndrome, Addison disease, congenital adrenal hyperplasia, Cushing syndrome. So we have elevated potassium, facial hair, large stature, dexamethasone suppression test 50. Well, it's not Turner syndrome since we have large stature.
Okay.
It might be Addison disease because potassium is facial hair. It's kind of make me rule it out.
Okay.
Congenital hyperplasia. So it's not Cushing syndrome. It's either polycystic ovary syndrome, or congenital adrenal hyperplasia.
What about that plasma 17 hydroxyprogesterone? We talked about that very briefly in the end of our last lecture. It's elevated, right?
Yes. So is it congenital adrenal hyperplasia?
Yeah, it's congenital adrenal hyperplasia. Yeah, absolutely. So this is one of those conditions that we talked about at the end of our last lecture, right? Especially this facial hair, large stature. This is a young girl, 14 years old. She reports menarche at 10. So there's definitely something going on. They give you this value. There must be a reason why they're giving you 70 progesterone, right?
Definitely. Thank you, though.
No problem. Dr. Who am I not asked? Oh, Dr. Anna Lee. Is your mic working?
Yes. A 40-year-old male non-diabetics presents with increasing headache and visual issues. On examination, he has enlargement of the hands and feet, coarse facial feature, and spreading of the teeth. What is the most appropriate first-line investigation? First is OGTT with serial growth hormones measurement, pituitary MRI, random serial growth hormone level, serial growth hormone releasing hormone level, serum insulin-like growth factors 1. Yeah. also will agree with the growth hormone, checking about the serum insulin like growth hormone.
Excellent, Doc. And how do you confirm it if it's positive?
Yeah. How,
If-
sorry?
How will you confirm it? If IGF-1 comes back and it's positive, what's the next test?
Next test, I'll go for MRI.
No, the next one we
Oh,
do is OGTT, remember? Because over here we're thinking about acromegaly, right? That's the condition. Big, big hands, big feet, coarse facial hair, the teeth are splaying apart, right? There's gaps in the teeth. So the first thing we do, IGF-1, and the confirm OGTT.
I see.
Excellent.
Yeah.
Who have I not asked? Dr. Amina, did you want to give this question a go?
yes, of course. Thank you. 43 years old man is admitted to the endocrine ward following a 1-month history of polyuria and polydipsia performed, which shows the following results. Urine osmolarity is at 37 millimole per kilogram, and urine osmolarity it's 45.
So it's low in the beginning and it's low at the end, right?
Mm-hmm.
What does that mean?
They didn't give us the plasma osmolarity.
Oh, but over here you have the urine osmolarity, which works as well.
Mm-hmm. So I will go with nephrogenic diabetes insipid.
Yeah, absolutely correct. Remember, if in the beginning it's low, and then you've given them desmopressin, you gave them ADH and it's still low, it means they don't respond to ADH, right? It means you're not responding to ADH, so the problem is not the brain, the problem is the kidney. If example, I think Dr. Albert wrote this, he's absolutely correct. In the beginning, if it was low, and then you gave them desmopressin, or you gave them ADH, and now it's high, it means the brain is not secreting ADH, but the body is responding to it. So so that in that case, it's cranial. Excellent. Thank you, Dr. Amina.
Thank you.
Dr. Farai, please.
The 31-year-old man presents with headaches, anxiety, and palpitations. On examination, his BP is found to be 195 on 120 milligrams of mercury. He is treated for essential hypertension. After failing to respond to initial medical therapy, he is further investigated for secondary causes of his hypertension and is diagnosed with pheochromocytoma. Which one of the following is the best for control of his blood pressure whilst awaiting definitive management of his tumor? A, bisoprolol, B, lamivudine, C, furosemide, D, labetalol, E, benzofumethiazide. Bisoprolol is a beta blocker. Beta is a beta blocker, so I would select that because you need alpha genetic blockade before that. Lamivudine is an ACE inhibitor, so I wouldn't use that. Furosemide is a diuretic, so I wouldn't use that. Benzofumethiazide is a thiazide diuretic, so I wouldn't use that. Labetalol has got both alpha and beta action, so I think it would be appropriate in this case. So I'll go with labetalol. Thank you.
What about everyone else? Dr. Frey, you're far too convincing. Absolutely correct. No, labetalol is the best one to go for, especially in this case.
Yes, sorry, why labetalol? Like labetalol over bisoprolol?
Dr. Farai, please. Why labetalol over?
Bisoprolol is a beta blocker. It's specific to beta 1 receptor. So it's specific to beta blockade. So we don't want to give beta blockers first in a patient who's got pheochromocytoma because you get unopposed alpha genetic activity leading to hypertensive crisis in a patient pheochromocytoma. So labetalol here is got beta blockade as well,
As well as
but also
alpha.
alpha blockade.
Yep.
So it covers both alpha and beta blockade. So that one is appropriate in this case.
A lot of the time as well, you'll notice that, especially whenever you have any patient who's got very, very, very high blood pressure, especially when you look at things, what's the one in pregnancy? I'm trying to think of right now. The one where they come in, no, preeclampsia, yeah, preeclampsia, absolutely, yeah. So preeclampsia, same thing. They can come in with extremely, extremely high blood pressures, and the drug of choice at that time is also labetalol that we go for. So most of the time when you have it's absolutely got to do with that same alpha and beta blockade. Whenever you have a hypertensive crisis and you're trying to bring the blood pressure down very fast without causing any sort of reactive, compensatory action, we end up choosing labetalol. It's a very good drug. It's very safe. We've used it for decades. We've got lots and lots of data on it. But it's usually that's what I've noticed. Whenever you want to bring the blood pressure down very fast, very safely, we end up picking labetalol for the alpha and the beta actions that it has. But yeah, absolutely. Yep. So these are all the links and all the places I've gotten my resources from. There's a few papers here I'd recommend you give them a read, especially the one that's talking about the hyperkalemia and the hyponatremia. Those ones, how do you correct them? Those are very, very important. This little website at the end is the same website I used to practice for my exam. It's ECG quizzes. It has a bajillion different quizzes on it for ECGs. Some of them are very, very advanced. Like as a person who's giving the AMC one, you don't need to know how to recognize like Brugada syndrome on like the ECG. But it's got some very, very difficult ones there, but it's got a lot of them are very good and very easy. I would recommend you do it. But thank you guys so much for being part of these classes and attending them with me. I've really, really enjoyed them. You guys have been absolutely amazing. I mean, just yesterday, I actually got a message from 2 of our last students from the previous cohort, and they've just passed their exams, and now they're applying for jobs here. And hopefully, I really hope to hear from all of you guys as well. Once you guys have sat your step 1, you're done, you pass, you text me, Umar, guess what? I'm applying for jobs in Queensland or in New South Wales or in Victoria. And I'm really, really excited. So I want to hear, there's 22 people here. I want to hear a message from all of you guys soon. But best of luck.
Yeah, Dr. Umar?
Yeah.
Sorry, could you quickly take the water deprivation test again?